Good morning.
Good morning.
Good morning.
Good morning, everyone.
Good morning. Morning.
Morning.
Good morning, Commissioner Anderson. Are you in Hawaii or just wishing you were there?
You'll never know. I have no desire to go to Hawaii.
Palm Springs, Washington.
That's where we're at. Thank you, Andre.
We just re-landscaped our backyard. You need to come see it.
Oh, looking forward to that. Especially you have sand and water there.
Good morning. It's 8:30, so we'll get started. I'm welcome to the board meeting, and I'm going to ask Ryan Ibach to take roll call.
All right, Commissioner Anderson, Board Chair.
Here.
Dr. Clary,
Here.
Commissioner McKinney,
Present.
Commissioner Lindy,
Here.
Mayor Byers,
Good morning.
Councilmember Duval,
Here.
Dr. Atterbury,
Here.
Yakima Health District staff, Andre Fresco. Here, thank you. Myself, Ryan Ibach, Chase Porter,
Here. Good morning.
Melissa Sixberry,
She's just joining the meeting.
all right, Lillian Bravo, all right, Melissa Sixberry,
Here.
Sean McGee, okay. Dr. Bard, Nathan Johnson,
Good morning.
Jocelyn Castillo,
Here.
Victoria Reyes,
Here.
James Elliott.
Good morning.
I'll go back, Lillian Bravo,
Here, good morning.
Sean McGee, and Dr. Bard. Okay.
All right. Thank you, Ryan.
You're welcome.
Go ahead. Go ahead, Ryan. We have a quorum, I assume, right?
Yes, all board members are present.
Okay, thank you. Then we'll move on to number 3. I assume that everybody received a note about the meeting process, how we're going to conduct the meetings. We're going to begin instituting some Robert's Rules guidelines so that everybody has an opportunity to talk about the subject on the agenda. And because just to give everybody an equal chance to express themselves or make their point. So hopefully you have that, and we were going to move forward with that. Any comments?
Dr. Bard to be absent from the meeting today?
He's joined the meeting.
Has he? Okay, thank you.
Yes, for the record, Dr. Barg and Sean McGee have joined the meeting.
Okay, thank you. All right, well then we'll move on to number 4, the submitted written comments. And Ryan, if you have any.
Okay, yes, we have 5 written comments. They all 5 written comments have been sent to the Board of Health. They will also be on our website so the public can view them. And so at any point during the meeting, if staff or the board members want to comment or address any of the comments, they're free to do so. So the first written comment is from Gail Molina. And actually for the first 4 written comments were submitted before the September 8th meeting for our special meeting that we did not have because of lack of agenda items. So just so you know that the first 4 items were submitted either end of August or beginning of September. Okay, so the first one is from Gail Molina. I'm writing to express my extreme disappointment in the Commissioners and Health Board's nay votes for Amanda McKinney's proclamation concerning mandated vaccinations, masking handed down by our extreme governor. The Commissioners and Health Board have a commitment to the people of our valley to be a voice and protect our rights, including our choice of medical freedoms. I recently sent a very lengthy research project I had done concerning the current COVID-19 vaccines to nearly every mayor, commissioner, and city council member in our area. The only person I heard back from was Amanda McKinney. That is pitiful. I could give you all a very long list of prominent doctors, researchers, PhDs, scientists who have much to say about the dangers of these injections, the studies that indicate safety issues with them, the fact that they do not provide immunity, as we are being told, but mainstream news outlets, the shoddy research done to approve them, lack of research about long-term health benefits, the faulty tests used to indicate a pandemic. I could go on, but it will unfortunately be ignored by many, as it is much easier to follow the crowd, digest the morning local news with literally no reporting on any of the dissenters' opinions, or step out and be a voice against a very corrupt political crowd, and go against a governor who seems to think he is a king and can send mandates down the pike that he considers laws. We need our voices to be heard. We need those in power to step up and step out. And we need you to protect our rights to medical freedom that is guaranteed in the Constitution. I noticed in a recent news article that the commissioners in Cowlitz County have stepped up to be a voice for their residents. And then the link to that article is listed. There are thousands of us across the great state who work in healthcare, firefighting, education, and state and local municipalities who now have to choose between our medical and personal freedoms or forced vaccinations. And many of us are choosing our freedoms. I wonder if any of you have your job on the line, jab or job. If you don't see something wrong with this scenario, then you need to be replaced with leaders who do. Now is the time to step up and demand our governor listen to and work with our local governments and our elected officials to protect our right to be the government, by the people, for the people.
Ryan, who was that letter from?
Gail Molina.
Okay, thank you. Just for the record, I did respond to Gail. Thank you.
Okay. The next one is from Ryan Amon. I am writing this email to implore you to take action like the college commissioners did on the mandates that have been imposed on Washington state employees. I am under no legal obligation to wear a mask or be vaccinated for the COVID-19 virus or PCR testing in any place of business, which is a place of public accommodation under both federal laws and Washington state laws as coded by RCW 49.60.030 and RCW 49.60.215. It is undisputed that there is no statute or law in existence that requires me to be vaccinated, tested, or masked, or that allows any employer in the state of Washington to grant or deny the continued employment or new employment of any person based upon whether or not they have received a COVID-19 vaccine or a PCR test. I have a vested constitutional right to my continued employment under the common laws pursuant to RCW 4.04.010, RCW 9A.04.060, CRR 1.1, Sutherland Statutory Construction, page 525 and page 2043. The forced vaccination or forced masking violates my constitutional rights under both Constitution, state, and federal, the laws of the state, the laws of the United States, and the 1964 Civil Rights Act, which are enforceable via Title 42, Section 1983. The next one was submitted by Dr. Jocelyn Pedrosa and signed by 14 other physicians at Neighborhood Health. Yakima Health Services has provided COVID testing, treatment, social supports, and vaccinations for thousands of our county's residents since the beginning of the pandemic. As primary care providers, we have seen the devastating effects this pandemic has had on our patients. We support the science that encourages strong public health practices to contain this deadly virus. We, the undersigned, affirm the following. Vaccines for COVID-19 have proven to be safe and effective. We strongly support the use of vaccines to help control the spread of severity of COVID-19 and encourage all individuals to speak to their personal medical provider about the importance of becoming vaccinated. We support the universal need for healthcare workers to be vaccinated to protect themselves and their patients. Universal masking among those who do not have a contraindication has been proven to be safe and effective in limiting the spread of COVID-19. Given the ongoing transmission of COVID-19 in Yakima County, we support universal masking among those who do not have a contraindication when in place that is generally accessible to the persons from outside their household. The next letter is from Dr. Marty Brueggemann and also signed by about 126 additional doctors. Our healthcare system is in crisis. The COVID pandemic has lasted longer than any of us have predicted, and wave after wave of illness have taken their toll on healthcare professionals and staff who are now exhausted and leaving their jobs in alarming numbers. This is a nationwide phenomenon, and this is occurring at a time when patients are seeking out care in record numbers for health conditions of all kinds, overwhelming our ability to care for them with the urgency they require. Our ERs are overrun and our inpatient beds are full. This is true in Yakima County and across the entire region and country. Patients who require specialty care often wait in one of our ERs for days at a time, waiting for us to find a bed anywhere we can. Now COVID is rampaging through our community yet again, and we have no more ability to flex and meet the demand. There is hope, however. We have a vaccine that is safer and more effective than any other vaccine in the history of medicine. This has the ability to turn off the constant barrage of critically ill patients requiring admission for COVID and allow for acute care facilities to focus on other medical conditions. As we close in on 200 million doses given in the United States, the data is now clear. These vaccines are safe and incredibly effective. The FDA agrees and now has fully approved the first of them. Even if our remaining citizens get immunized today, though, the benefits are still weeks away. In the meantime, we have another highly effective and perfectly safe tool to control this pandemic and ease some of the burden on our healthcare system. Time and again, across cities, counties, states, and nations, we have proven over and over again that masking prevents the spread of this disease. It takes everyone for this tool to be effective, though, not just those who choose to do it to protect their fellow citizens. Last summer, as cases surged in May, our masking compliance in Yakima County was at 35%. The relentless efforts to promote masking and general mandate for their use, the compliance climbed to 95% in early July. This coincided with the drop-off in cases and effectively ended our first wave. Our current wave of COVID, which is proving to be the most significant yet, began exactly 2 weeks after the mask mandate ended in late June. This is no coincidence, and the addition of these COVID cases on top of our already stressed system has put us in crisis. As the undersigned leaders of the medical community in Yakima County, we support the vaccine mandate for healthcare professionals in order to ensure the safety of our patients and integrity of our workforce. We further support the masking mandate for the general public and control the relentless spread of this deadly illness in our community. We, the undersigned members of the Yakima County medical community, affirm the following. Vaccines for COVID-19 have proven to be safe and effective. We strongly support the use of vaccines to help control the spread of severity of COVID-19 and encourage all individuals to speak to their personal physicians for any questions about vaccination. We support the universal need for healthcare workers to be vaccinated to protect themselves and their patients. Universal masking has been proven to be safe and effective, limiting the spread of COVID-19. And then the last one is from Kenton Drexel. Thank you for taking the time today to read my comment in the public comment section of the public meeting that's scheduled. I've attached a photo of the public record request I made of our coroner's office, who is to verify people who have passed away, as well as many duties performed by the coroner's department of Yakima County. Why is the coroner's data, which shows zero, completely different from the hospital's data, whose job it is not to confirm cause of death? I would like to know also why the Yakima County Commissioners and Health Board has not intervened in putting a stop to HIPAA law violations, medical privacy violations, as outlined in Roe versus Wade by the Supreme Court of the United States. Why it has allowed for entities within our county to practice Jim Crow style policies in creating segregation, discrimination, and an invasive policy upon babies, youth, adults, and senior citizens. What are you going to directly do about such discriminatory policies being enacted with excuses pointing to your departments? I got one, do not tolerate Jim Crow style politics. My family came from Norway, and my great-grandfather helped people from the Depression on to avoid all these hardships. I'm extremely frustrated and will not be allowing any money I spend on any entity that is doing this. Your departments can and are capable of putting a direct stop to which is legally sound under Roe versus Wade, or did privacy of all of a sudden go out the door?
That's it?
All five of them.
Okay, thank you much. Appreciate it. We'll move on now to number 5, the consent agenda. It's a motion to approve all items listed with an asterisk. So is there a motion to approve the
Mayor Byer, motion to approve.
Thank you. Is there a second?
Commissioner McKinney, I'll second.
Been moved and seconded to approve the consent agenda. Is there any discussion? Hearing none. Ryan, would you take a poll, please?
Yes. So voting for the consent agenda, Dr. Cleary,
Approve.
Commissioner McKinney,
Aye.
Commissioner Lindy,
Aye.
Mayor Byers,
Yes.
Councilmember Duval,
Yes.
Dr. Atterbury,
Yes.
Commissioner Anderson.
Yes. Thank you much. Now we'll move on to the board business and Director Fresco.
Thank you, Commissioner Anderson. Good morning to the board and good morning to our guests. Thank you for joining us today.
First, if I may, Jocelyn, would you be so kind as to expand the size of the agenda page, please? It's a little tough to read. Thank you so much. I'd like to begin today just talking about an update on COVID-19. Obviously, it's front and center for our attention. We had discussed at our previous meeting that we hoped that during the summer months, and certainly with increased vaccination, we would be a safer and more protected community. That's not been the case. And since we last met, we've had two interesting things happen. We have school fully in session, and also the federal government has authorized the use of the Pfizer vaccines for a third dose, or what is being commonly referred to as a booster. So that process you'll hear more of during our meeting. I wanted to just mention that those two events are important because we had hoped that we would be farther along as a nation in terms of having access to booster shots. That hasn't been the case. And again, you'll hear more about the fact that the boosters are for certain members of our population only at this point. The other reason I mentioned schools is that you'll hear more about schools and the number of cases that we have, because we do have an increased number of cases. So we are no means out of the woods in terms of safety for our community, but we are taking steps here to be a responsive agency to respond to the needs of the community and to prepare for what we anticipate to be the next few months of needs for testing and vaccination. As we've discussed, it's our expectation that the closer we get to colder weather, the more need will be for testing, because we may have increased cases. So we're planning for that. You'll hear more about our plans at the State Fair Park and the return of testing and vaccination at the State Fair Park. But we are in the process now of creating systems for support for our community that have to do with the need also for testing, because this month, or rather, I'm sorry, next month, mid-October, we'll have a deadline for people to either be vaccinated or have an exemption or test regularly. So we anticipate the need for more testing as well. So we have relied on testing throughout this process, but we feel that there's a need for more testing, more options for testing. And we're also anticipating the need for drive-through testing and vaccination because, again, we've got colder weather coming. So we're in the planning stages now for what we believe we'll need to do to be supportive of our community in winter months. So you'll hear a lot about that. It's a process where there's a great deal of planning and operational support that's required. But I wanted to mention to the board that this is something that we've done before. This is one of the reasons we work with our committed partners to ramp these things up, again, when the community requires it. So that's what we'll be working on. So I wanted to just give you a brief overview because, again, there will be other reports in this meeting that will go into more detail, if that's okay with you. Any questions? Okay, thank you. The next component of my report is our 2022 fee hearing. Again, we have fees at the health district, and we have an open meeting process to explain those fees. And that's part of our responsibility to bring you a proposed budget. So Ryan, I'll ask you to review that process, please.
Okay. So the notification of the fee hearing was advertised to the public in the newspaper and also has been on our website. So at this point, Commissioner Anderson, we just need to open up the fee hearing portion of the meeting.
I now open up the hearing for fee changes consideration.
Okay. There were no changes to the fees for 2022, and we did not receive any comments or input from the public. At this point, if there's any discussion from board members before we close the fee hearing, and then we go on to a vote for the fee schedule.
Any comments, questions?
I only have a question, Ryan. So in this case, it's an open hearing, so we're still voting today, or are we making a motion to move it to resolution for the next meeting?
Yeah, we vote today.
Okay.
Any further comments?
Well, I'll just say that, you know, if there are no changes to the fee schedule, I don't have a comment or concern.
Anyone else? Hearing none, I will close the hearing.
Okay, and so now we just need to vote on the fee schedule for 2022.
And Ryan, would you
I will
conduct a
vote
poll?
to make a motion to approve the 2022 proposed fee changes, which are none.
Is there a
Second by
second?
Mayor Byers.
Moved and seconded. Ryan, would you conduct a poll, please?
Yes. So if you're in favor of the fee schedule, please say yes. If not, say no. Dr. Clary,
Yes.
Mr. McKinney,
Aye.
Mr. Lindy,
Yes.
Mayor Byers,
Yes,
Councilmember Duval,
Yes.
Dr. Atterbury,
Yes.
and Commissioner Anderson.
Yes. Thank you much. Appreciate it. Now, we're going to move on to the proposed budgets.
Yes, thank you. So again, this is our opportunity to introduce our proposed budget to the board. This is for your review and certainly discussion. This is a high-level introduction because we'll give you the proposed budget for your review. We do this early in the process because by law, we have to have an adopted budget by December 31st. Our normal operating model is to introduce it today or in this month's board meeting. And in October, the anticipation is if it meets with your expectations and you approve it, then we have an adopted budget early. If not, we anticipate having the opportunity to have that budget adopted at our December board meeting. I will certainly hand this over to Chase so that he can get into more specifics, but I did want to share that what we're bringing to your attention is a large budget, and that's because of COVID. Our normal operating funds, the expectations that we have for revenue have not changed dramatically for our regular programs, but the need for COVID support has increased dramatically. And I do want to share in full disclosure that our normal operating model for preparing a budget under Ryan and Chase's direction is to bring you a budget that has funding that we've already vetted so that we know that the funds that we're going to spend are already going to be received in that fiscal year. I do want to share in full disclosure that this has been a very different process for receiving funding. The federal government is not going to tell us in advance, nor is the state, how much funding they're going to give us in 2022. So we have been given assurances about funding for things like vaccination and so forth, but we don't have a guarantee. What we're trying to bring to you is our best efforts to anticipate the costs for providing a full-scale response to this dramatic emergency. And so if you have questions, please feel free to bring them up. We're available throughout the month to answer more specific questions. The last thing that we want is any complexity and misunderstanding. So if I may, I'll pass this to Chase and he can explain it to you.
Thank you so much, Andre. Good morning, everyone. As Andre was saying, Jocelyn, will you please bring up the budget, please? As Andre was saying, we'll present it today and we will hopefully be up for adoption next month. This budget will be available. We'll send this out to the board members after the meeting sometime today. A copy will also be available on our website, and we'll make a copy available at our front desk for anybody in the public that may want to view this. As Andre is saying, we want to kind of mentally prepare you for a very large budget. As he was kind of detailing, we are deviating slightly from the way we've done in the past. I've always budgeted for secured funds, but right now 2022 is very hazy. It's hard to see exactly what's going to happen. As we've seen in the past, the past year, our experience has been, the money's been there. The FEMA has been there. DOH has been very supportive. The issue is timing. FEMA will only do guarantee money 90 days out. That's as far as they'll go. So we're looking, 15 months out. So we're assuming that FEMA will continue to support us. And if the money's not there, we won't have those activities. So we'll get into some of the meat and potatoes here. Next page, please. This is our full-time equivalents, the list of our full-time equivalents. We have 33 full-time equivalent employees here. Last year we had 32. The addition is more or less the health officer. The health officer is now considered an employee at Yakima Health District for insurance purposes. Any questions about full-time equivalents? This is our regular staff. If we remove COVID, this would still be our staff today or tomorrow if COVID was no longer in play. Next slide, please. And this next slide is detailing what our temporary employees are, our temporary or our part-time employees. There's been so much additional work here. As you can see, we've hired 3 new admin staff, looking to, because there's just been a lot of administration work here, a lot of new bills, a lot of paperwork, a lot of hires. As you can see into the next disease control team, we have an epi and a lot of health service consultants. They're our front line against, collecting data and fighting COVID. And we're needing also help with our communications.
So
that's
Chase,
yes, sir.
I'm sorry, excuse me, Chase. So just a question on this page with the temporary full times, what reflection or what kind of change is this from a year before?
You mean from prior year?
Yeah, from prior year level.
Yeah. Last year, prior year, we didn't have temporaries set up like this. Department of Health hired all of our health service consultants. We didn't have an epidemiologist at the time, and we didn't have the funding for an epi. So we, at that point in time, this time last year, we wanted an epi, but we were leveraging DOH's help to do those things. As money's come available, DOH has sent money our way for these positions. So that's really the main is 2021. We've really seen just an increase of the Yakima Health District's participation with that. All these positions, at least for the disease control team, were Department of Health employees through the end of 2020. And Department of Health didn't want to do that anymore. And so now they've given us the money to administer that.
And Commissioner Lindy, I'd like to also share that within our adopted budget by the board, there are times when we've had to ramp up increased services. And so we'll hire a temporary employee. What's unique and what Chase alluded to is that we have teams of people working on issues that are unprecedented that we've never actually done before. So that's where the distinction is and why we wanted to make it very clear to you that we've got people working on public health response that was not even a discipline or a need in years previous.
Great, thank you.
Okay, next page, please. Okay, can you, there we go. Maybe a little bit more. Zoom in one more time. How does that for everybody? Is that, there we go. That's much better. Is that okay for can everybody see that okay?
Yep.
Thank you, Jocelyn. So as you can see with our new admin staff, that's really the biggest increase as far as our indirect programs. Indirect programs are mainly administration. There's no direct funding for that, but that is a very essential part of the business plan. Those fees, those cost expenses are allocated out to direct programs. So we're going to see an increase in admin support time and also an increase in attorney fees. We have a lot of interesting new laws coming out regarding public health and having to fill our, as you guys know, our Board of Health. And so we have a lot of issues that we need legal support. The other two, community environmental health, just those decreases are seen. We're moving people into the COVID response bucket, so to speak. Yes, we scroll down just slightly more so we can just see all the direct programs if possible. A little bit more. Maybe we can see the bottom line at the same time. Okay, that's good. Thank you. Hopefully everybody can see that okay. I'm going to go through these lines, but if you have any questions, please stop. Strategic planning and partnerships, that's mainly Lillian's team. And that's also being moved down into the COVID bucket. Our increase in auditing costs, that's a possibility. Everything costs more nowadays. And also again, with our increase in human resources and other legal costs that are attributable to direct programs. COVID direct programs, while we're talking about wax and those kind of things, that would be administration attorney fees. So that's the differentiation between those two. That's why you see those fees in two spots. Community health, again, we are more or less moving people as far as the costs go, increasing that. That's for our nurses and those kind of things. But the decrease is more or less moving money back into the COVID bucket. And again, right here, you can see the COVID bucket, $13.3 million, $13.4 million next year. That is very sizable. And just real quickly, if you look at the very bottom, 13.3 million, you can see that's the majority of our increase. So that's very easy to spot that. Medicaid admin, slight decrease. Increase in expected funding for AFIX, that's vaccinations. Obviously, that's going to be the flu and all the other things is top of mind as well right now. The breast cervical health program, which is the BCCHP. We've shortened the acronym, the BCHP. But last year, there wasn't a lot of activity in that program. Everything was shut down, right? Most services weren't being provided. Services are opening back up, and so we're seeing an increase in that program. Moving into environmental health, drinking and solid waste. We had an increase in FTEs last year, and that increase on this budget is to reflect that. Slight decrease for land development, that's our on-site septic program. Slight decreases for food, pools, and vector. Developmental disability, we had a slight decrease in contract, and that had a lot to do with the slowdown in the economy. There's just not enough taxes to collect.
I do have a real quick question if we could back up. So the land development and septic decrease, were we scheduling FTEs to spend less time on those items? Because I know in the building community, we had a really big concern that we weren't getting things done during COVID in a timely manner, and it slowed down building. And so I'm just wondering if what's the decrease? Is it a—
Oh yeah, so the decrease is mainly travel. And training. So if you notice the far right columns with the 0.1, the 0.433. So for this one's 0.25, 0.21. That's the changes in FTEs. So for the on-site septic, there was no change in FTEs. The change would be probably decreasing slightly for like travel or training.
Okay.
We're not going to. We would go to like Bend, Oregon for training and other things for training. We're not doing that. And if there is training, it's online now.
Mm-hmm.
So there is no travel expenses associated with that anymore. So no, as far as that goes, decrease in program due to demand, and that's mainly just travel demand.
Thank you for clarifying.
Well, you're welcome. Again, on the vital records, just a decrease. We're seeing people doing online services for that. And then increase for our public health emergency response, a slight increase in FTE, but there's other operating and even more travel expenses than now for that program. But overall, as you can see, our budget changed. If you eliminated COVID, it would have been almost exactly the same as last year. So you can really see that this budget is COVID driven. As Andre was talking about, we are planning a little bit different this year because we're having our guaranteed FEMA funding expires in December, but we've had discussions with DOH at least once a month, and they are fully expecting that to go forward, as everybody does. It's just the way the FEMA works, and so we're working with them, and so that's the drivers behind a lot of these increases or changes.
Chase, if I may also add, if we were to look at our proposed budget in thirds, 7 million of it is really the normal course of business that we brought to you last year. You were supportive, and thank you for amending our budget to 14 million this current year. The distinction is that during our response this year, when we had to ramp up for really increase vaccinations community-wide, that was accomplished through a partnership with FEMA, and that was paid for directly by FEMA. And so we had the benefit of federal support, federal staff, and federal dollars. And we won't have that this year. What we'll have is, and it is unique, and I want to point out, it's something specific to our profession, but currently the FEMA funding is 100% reimbursable, which is not normally the case. So that's to our benefit. But I want to be very clear that whatever we spend on this response that's reimbursed by FEMA comes through our department, which is one of the reasons why you see an additional increase of money. And that's why the proposed budget is so large, because we anticipate if we have to vaccinate more people for a booster or for those 5 to 12, we will certainly be doing so through our agency.
Yes, thank you. Thank you for that, Andre. That's a very great point, that Department of Health, a lot of these expenses, Department of Health was covering directly last year. That did not run through us. And we had to amend our budget just for the few things they wanted us to do. So that's really what we try to build in this year. And even this might be a little on the light side. If they wanted to open, it's similar to what we were running this past, spring. This could potentially be a lot more. However, before we get into those activities, the funding will always be secured.
Chase, I'm wondering if you or Andre could comment. I don't see any additional funds or line item in this particular budget for mental health screening or the mental health impact of ongoing pandemic, which clearly there will be for the next year. And so I'm wondering, is that covered under the COVID-19 response and just not line itemed, or is that not being anticipated?
Well, not specifically. We have some high advertising budgeting expenditures. Right now, our main goal is to continue to fight COVID. As far as mental health, there is a DOH program that Lillian just received for the communities, but that was only like $35,000. So right now, the funding and a lot of the activities, a lot of the focus is just continuing to get the community physically healthy before the mental part. We certainly have not, we've been thinking about that. Lillian has purchased an app that can be used by anybody in Yakima County for mental health. So Dr. Atterbury, that's something that Andre was actually talking about and planning for 2022, but it's just looking like COVID is just going to be still the main drive. I'm thinking that, in our discussions, it's probably going to be 2023, 24 when we start seeing the actual kind of like the fallout, working on I'm forgetting how Andre will put it, but working on the illnesses that come as of the result of this. There's going to be illnesses that result from this that we're not seeing right now because we're so focused on COVID.
Yes, Dr. Oh, I'm sorry.
I just wanted to quickly mention, yes, at this point in time, it's definitely something that we want to continue to message about, continue to raise awareness about the different mental health, behavioral health issues. But at this point in time, we're really doing more messaging and a supporting role to our behavioral health agencies in the community as a public health agency, wanting to push the message, but really being a supportive role to the other agencies that are working on this as well throughout the community.
Yes, Dr. Atterbury, it's a very fair point. It's a concern that we have, and it's a heartache to know that there are increased psychological traumas that are a result of this response. We have talked to many of our partners, and one of the issues that's facing our rural community, like many around the country, is lack of mental health professionals who are available. There certainly are openings for those with our partners, but they're just not enough qualified individuals to meet the demand. Dr. Lindy, or I'm sorry, Commissioner Lindy, do you have something to share?
Yeah, just I appreciate the comments here about mental health, and I'd just like to piggyback onto Dr. Atterbury's comments in that, it seems that although this is certainly a concern, one of the things that we can do to assist with mental health is continue the effort to keep our kids in the schools, keep our churches open and the businesses operating. I do think that is a portion of that whole mental health issue.
Well, thank you for bringing that up, Commissioner Lindy. One of the things that was, as Chase alluded to, was that when we were in the planning stages 6 months ago, our hope was that summer would reduce dramatically the spread of this illness. We also anticipated or hoped that more people would become vaccinated. The goal was to begin a containment process around COVID and then begin to work on the the post-recovery efforts that, as I've shared, and I know you all feel, will be with us for many years. The effects of this pandemic, this disease on our community, on individuals, on families, on children. What we did not anticipate was that we would have a dramatic new variant that would have such a devastating effect in our community. And also, to your point, Commissioner Lindy, our community is open. And so having schools in session required us to have an outbreak response team that was prepared to handle what we anticipated to be and what has happened, more cases. So the process of investigating cases, advising our colleagues and our partners on how to address these issues and maintaining an open community has been our focus. And so all the things that we wanted to do post, I'd say, recovery phase that was expected is not happening now. I share that with you because, again, we are in a dramatic situation where this is a whole new initiative now. We are moving into an area, and I can't underscore my concern, that we have never had a response to COVID that included all children in school and also moving into winter. So we have the concerns, I know you know as a physician, concerns around flu season, cold season, pneumonia. We have not seen that during COVID because we largely had an absence of those in our community. Those will be, I think, in full effect. So we are planning for a difficult time. That's part of what we do here, not to be negative, but to ensure that we have alternatives. We're looking for solutions in a tough time. But again, to Commissioner Lindy's point, we want to maintain an open community. That's our focus.
Yeah. Thank you. I appreciate that focus. I really do. You know, one of the things that I've seen as I've talked to parents and kids and especially teachers is that as they've done assessments on the kids and what they've been able to learn or not learn, the last 18 months academically have been really tough on kids. And so I appreciate those efforts to keep the schools open.
Any other comments on that?
Yes.
Go ahead.
This is Mayor Byers. So I just want to kind of reiterate Commissioner Lindy's position to have our schools open, churches open, businesses open, I believe has had a positive impact and creates a greater atmosphere of hope to move forward through what we're going through right now than having everything closed down again. So appreciate all the efforts for that. I know early on in my talks with the legislators and the governor's office, and then when I came on the health board, I've had great concerns about the whole mental health aspect of what our community has gone through as individuals go through this and we go through this as a community. So I think, working to stay as open as we can, offers hope and opportunity for that. I still do have great concerns because it's not like all of those issues are coming down the road. All of those mental health issues are going on now, and and I'm very aware of the shortage of workers to provide the services needed in the mental health field. And I don't know as a Board of Health, what we can actually do about that other than, as Lillian said, I think, offer support in encouraging people to use those services, but we certainly need to find a way as a community to increase the services we have available here in our valley. So.
Mayor Byers, we share your concern and we're open to any suggestions that you have and any partnerships that we can deploy in the coming months. And I believe Dr. Cleary, did you have a comment to make, sir?
Yes, I did. So this is to either you or Chase. 14.5 million is kind of a large number to have under a single line item. And I was wondering if we could expand that out like under environmental health to see what was spent this past year on programs and where this is expected to go to. I assume that some of the COVID programs will actually decrease in funding, like the contact tracing and such.
Dr. Cleary, actually contact tracing and those things has actually increased. We're still very, very deep into that stuff. It's still requiring a lot of time, a lot of employee time. So this time last year, yeah, we were expecting things to be decreased and they just have not. This time last year, we were expecting, vaccines to go out in April and to have 90% of the community vaccinated by October. So we would be experiencing herd immunity right now. That has not happened. I don't, as far as, I'm sorry, sorry, Andre?
No, after you, Chase, I was going to add something, but you're correct.
Dr. Cleary, that is the difficult, that's what, we've really been struggling with this past few months is that predictability, how we're going to do and where it's going to go. That is certainly what we're seeing is that there is still a very high need in the community for these services. And it's not going anywhere unless there's a dramatic shift in the public perception.
Dr. Cleary, one thing we can do is what we did have done in previous board meetings is we had a projected COVID expense budget. So we can work on that for you. One of the distinctions is that, again, or I guess I should say currently in our current fiscal year, many of the costs were paid for directly by the Department of Health or the federal government. So we had people working on our behalf, but we worked very hard early on, actually last year, to secure a relationship with the governor's office and the Department of Health, where Yakima, as a socially vulnerable community, and also because of the dramatic number of cases, was receiving additional funds. And so we had a relationship built to do that. That is now not possible because the federal government is funding differently. But your point is well taken. There are very large costs associated with things like having an outbreak response team. There's large costs associated with having a drive-through site at the State Fair Park. So we can share those large items so you can have a better understanding of where the money's going. Happy to do that.
There's a few slides after this that actually might be a little bit more helpful if we're looking at details. I can certainly get some more details, but this is just a summary page. So maybe a little bit deeper into this, there might be some answers to questions.
Okay, thank you. I recognize it's not exactly predictable, but I think for 13.5 million increase, we ought to be able to show a breakdown of where that's expected to go to.
Sure. Any more questions about the summary? Jocelyn, will you move down to the next page, please? So as I reviewed the summary, I am not going to go line by line on the detailed. So this is our every program that we're running here at Yakima Health District by the TITO. What you're looking at was a summary. This is the detailed version of that. Will you scroll down a little bit? And I just wanted to point out, well, first of all, epidemiologist is the first one right there, right underneath community health, communicable disease. Last year, we had 0.05. We didn't have for an FTE, $10,000. That was not, we were still leveraging DOH for our epidemiology work. Now we have $150,000 of full-time FTE on site working right now. So things have changed quite a bit year over year. And then moving down into the COVID response, as you can see there, Dr. Cleary will certainly get you some more detail around that. But that's kind of how we're seeing it breaking out by program. 325 is mainly internal, as well as 326. The COVID vaccination partnerships, that 7.8 million is going to be mainly testing. Vaccinations. That's going to be FEMA dollars. And the response is testing that DOH is funding. And then the last, the outbreak response 328 is all of our health services consultants. So that's kind of the program breakdown on that. Dr. Cleary, I can certainly get you a COVID budget as far as like salaries and all that other stuff. The majority of this vaccination partnerships is Columbia Safety, Yakima Valley Memorial Health for COVID testing and for vaccinations. They're very highly compensated employees for those type of positions. Again, going on down, you'll get some more detail on the EH programs. Do you mind going down to the next page?
While you're moving down, Chase, if you can send all of us that breakdown, I think that'd be helpful.
Oh, 100%. You guys will all get this this exact PDF. And then if you scroll down to the very bottom, you'll see the same changes as far as just to the very bottom, Jocelyn, please. There we are. There's that increase of almost 11 FTEs. Or yeah, 12 FTEs. Amazing. Okay, next page, please. We're moving down into our what would be our income statement. Please scroll to the left a little bit. we're going to cut the enhanced piece off a little bit for right now. The majority of the increase that you can see is all federal funding, FEMA funding coming from the federals. Our state was a decrease just because we're expecting more FEMA funding than state funding. Our fees and our developmental disability have also increased, as well as our anticipated investment income just for the allocation for the national slowdown. We're just seeing less returns on our investment income. Salaries and wages, we've got an additional 12 staff. That's a pretty penny. I did not explain anything under any change under $2,000 was not explained. That's considered de minimis, just slight increases and decreases within programs. We'll scroll on down. Our health officer salaries is now up in salaries and wages. So there's a little bit of a push right there, increase in legal and technology. We bought like 100 iPads last year. So we're spending a lot in new tech. And then there's our provider services, other $12 million. And that's our COVID testing, vaccinations, that's the Columbia Safety, Express Employment, CMS, all of those guys, the Yakima Valley Memorial Health, that's where you're seeing that. And that's the large increase. That's where, our partners are going to be out in the community vaccinating and testing. I'm not going to really touch on any of these other increases or decreases. I could certainly speak to them if there's any questions. Moving on down, please, Jocelyn. So coming down to the very end of our budget, again, some rental storage, that's rentals for parking lots and places like that to administer vaccinations and tests. So here's our full budget of $20.4 million. We like to have, or there's a piece that we always have in the past, our enhanced budget. That's for any additional technology or investments, any community investments that may come up in the year to try to spend down any large increases that we have.
If I may add, oh, I'm sorry.
Yeah, go ahead, Andre, please.
No, I think I heard someone else. No, okay, thank you, Chase. I was just going to add the enhanced was our attempt to use our reserves to the benefit of the community. So if something comes up, we have the opportunity. We've worked with the board chair in the past with the idea of having investment strategies for that. And to Dr. Atterbury's earlier point, our hope was this year that we could really invest in a long-term strategy for our recovery efforts, but we are really centered again on COVID. So our hope is to do that, but I think this is the year that we plan that as opposed to begin that process of investing towards an improved community post-COVID. We're not there yet.
Yeah.
Andre, I've got just a question about your statement you just made. So you've said in the past you worked directly with the board chair. Are you referring to the health board chair?
Yes, what we did was we as you know, we have reserves. And so one of the things that we talked about was how would we begin to use reserves to the benefit of the community. And so in years past, what we came up with was a strategy with our board to begin to use those funds, what we refer to as enhanced funds. And so that's been part of our process for the last few years, is to have enhanced funds available. And so when I say work with the board chair, the idea was to agree that we were going to come up with a strategy to use reserve funds for that benefit. And so that's what we've had in the last few years, is an enhanced component to our budget.
So I just want to make sure. So you've interchanged board chair and health board. So when you're determining where to send this money, were you working with the entire board or just the board chair?
Oh, I'm sorry. No, this wasn't about the use of the funds. It was about the structure of coming up with a proposed budget that included the funds.
So when you were coming up with your proposed budget, were you working with the entire board or just the board chair?
No, we're working with the entire board. So the process now of introducing the budget to you includes wanting to have an enhanced component. So we're working with the board right now the way we've done in previous years. Okay. When I share with you that we work with the board chair, we began the discussion with the board chair in previous years because we had reserve funds that we wanted to deploy on behalf of the community and wanted to come up with a strategy. The strategy determined with the full support of the board was the concept of having an enhanced budget that included those funds. So we've worked with the board in the past, and we welcome the thoughts of the board on how that money should be spent.
Thank you for clarifying.
Thank you.
Well, that's our presentation. 20 full budget of 20, just under $21 million. Wow, that's wow. I'm still a little blown away by that as well. Increase of 13.3 million.
Okay, well, thank you, Chase.
Yeah, I'm sorry, Commissioner Anderson. I just want to say, yeah, this is available now for any questions between now and our board meeting at the end of October. This will be available to you and the public in many different places. And so hopefully, if you have any questions, please let me know so I can get you comfortable or prepared for our October meeting. I'm really hoping we can have an adopted budget by the end of that meeting. So if you have any questions or concerns, please feel free to reach out to me, Ryan, or Andre about those so we can get you comfortable and or maybe even change our budget if that's what we need to do. So please let us know, and I'm hoping we can get into a spot where come this time next month, the entire board is comfortable with this and ready to adopt it.
Okay,
I
thank
have a
you.
question. I know that there's a lot of different programs and this is kind of really high level. Could we get a list of all the smaller programs, everything that's included and what funds are allocated for each program?
Sure, that's actually included in the budget. Can I show you that real quick again? Let me make sure that it's answering your questions, Commissioner McKinney. Go up to the detail of 2 pages. Okay, there we go. This is a good place to stop. So 615, the very top woman, Wise Woman. Last year we budgeted 98,000. This year 103,000. That is all federal DOH funding to promote healthy lifestyles for BCCHP clients. These are all of our client our programs here, Commissioner McKinney. We have them all broken down by like you see the BCCHP program has three programs with inside of it, but if you went up to the summary page, we would just be reporting at that summary level. So this is the detailed per program, how much we're budgeting for that program.
And is there a way to get confirmation on which are required as a function, statutorily required by the health district, and then which ones, you know, are not something that the board and has determined to, you know, voluntarily adopt a program?
Okay, we can certainly do that.
Perfect, thank you.
Okay, any further questions?
Just one question for you, Chase. I just noticed it stands out under colon screening. It's got a 0 allocation. Is that because there's no money being pitched toward colon screening, or the emphasis was placed on breast and cervical cancer screening and that ended up eating up all the budget?
Yeah, so the colon screening program has more or less gone away. We've had that in years past, and we actually have a little bit of money this year. We got a little bit, like $5,000 in DOH money. We haven't removed that because we do get occasional money from DOH for the colon program, but more or less that program has been eliminated.
Yes, that was at the federal level that the program was eliminated.
Gotcha.
Thank you. Any further questions?
Just a clarifying question. I thought you told us that you're going to be sending this all out to us shortly, correct?
Correct. It'll go out later today via email is the plan.
Okay. Thank you, Chase.
You're welcome.
Thank you. Okay, well then, if we're ready, we'll move on to the financial report for August.
All right, you guys got more of me. Lucky you. Moving down into the summary, please. We had a gain of approximately $119,000 this month. We had something a little unusual that drove that gain, bringing our annual excess revenue to $141,000. Our allocated budget for revenue was $5 million and expenditures $5 million. That's before our approved budget amendment. So you can see for what we've allocated our budget and our cost year to date over what we've been over budget for our original adopted budget in 2020. It's about $3.2 million, $3.3 million. Any questions on the summary page? Moving into the next page. Last month, we got an investment by $50,000. You see that over on the far left, non-governmental contributions by the Kresge Foundation. That's a foundation that Andre and Lillian approached about 3 years ago now. For mainly, they would have to speak to what they were doing for Kresge, but it's just pretty amazing that foundation is continuing to invest in the Yakima Health District. This is a national foundation that could be investing money anywhere, and so that's really a great thing to see that this national foundation, where they could be spending their money on COVID anywhere in America, they're choosing Yakima Health District, and Andre and Lillian were the drivers behind that. So that's excellent to see. Moving on down into the expenditures. I'm just going to point out quickly the 900 right underneath professional service, other $920,000 for the month. Wow. That's COVID vaccinations and testing. We'll get into the COVID income statement, but I just wanted to point that out. Almost $1 million in there. Wow. So moving to the next page, please. This is our looking at our final income statement for August. We spent about $1.5 million in August. Moving into the COVID page, please. Oh, I'm sorry. Here, I'm getting a little ahead of myself. We're now into programs. And again, I'm not really going to speak to anything on here unless there's any specific questions. All right, keep scrolling, please. All right, move into the COVID statement, please. So here we are. Of those professional services, you see that right there, $917,000. $760,000 was Columbia Safety for vaccinations. And then the rest, the remaining was for testing. And I just would like to point out that this is just testing in Sunnyside. So about $150,000 for testing in Sunnyside. UW was doing the testing up here. So $1 million in COVID expenditures for the month of August. Wow. Okay. I think it makes sense. Is there any questions regarding that? Okay.
No questions? Go ahead.
Yes, sir. Okay, last page, please. At the end of August, we saw a slight uptick in our cash and cash equivalents to $8.5 million. And that concludes my report unless there's any other questions.
Any questions for Chase? Go ahead, Commissioner.
You know, I don't know if this is a question for Chase or not, but he brought it up about the testing side and the expense there. And I'm just kind of curious if we have any idea. I know we get the testing or the vaccination status daily from the health district, but I'm wondering, do we have a feel for how many vaccinations are given at private firms, through local pharmacies and clinics and that kind of thing? Because what we see on the CVC report is just simply the, what's done at various public sites that aren't necessarily medical clinics. And you're probably not the one to answer this, but your statement brought that up. And if we're answering this at a different part of the program, that's okay too. But I just wanted to throw that out there.
Commissioner, I can answer that real quick. We don't have that. Organizations don't report that directly to YHD. When a vaccine is given, that's reported into the state database and then therefore reflected on the overall county number of how many first dose and second doses. That's on the state level dashboard, but that's not reported directly to YHD to be able to pull. Okay.
So we get the information, but we get it kind of circuitously that way.
Exactly. Yep.
That's an understatement.
Okay.
Commissioner Lindy, you do bring up a good point, though. Not many people are familiar with the term health literacy, but we find that there are many people who have difficulty navigating the medical or pharmaceutical systems. So one of the reasons that we worked very hard to create mobile teams or opportunities in our more rural parts of the lower valley was to ensure that people had access, consistent access that they understood in both English and Spanish. So that's our commitment to making certain that people from all walks of life within our community have access. And that's proven to be very valuable for us, and certainly been able to assist in getting people safe solutions, but it has come at a cost.
Thank you, Andre.
Any further questions? Thank you, Chase.
Thank you.
Now I'll entertain a motion to approve the August 2021 financial report.
Move, Mayor Byers.
I will second Commissioner Lindy.
Been moved and seconded to approve the August 2021 budget. Any further discussion? Hearing none. Ryan, would you please take a poll?
Yes. Okay, to approve the financials for August, Dr. Cleary,
Yes.
Commissioner McKinney,
Aye.
Commissioner Lindy,
Aye.
Mayor Byers,
Yes.
Councilmember Duval,
Yes.
Dr. Atterbury,
Aye.
and Commissioner Anderson.
Yes. Thank you all. Thank you. We'll now move to the department reports. And first up is Chief Operating Officer Ryan.
All right, the first thing I want to talk about is schools and the data that we're seeing in schools. So Jocelyn, can you pull up the school data? Jocelyn?
Sorry, are you able to see my screen now?
No, not yet. Okay. Okay, so this is the data that is sent out to the school districts, all the school nurses and superintendents every week, and also to the Board of Health members. The column on the left-hand side is totals for last school year, and you can see down at the bottom what the totals were for the last school year. The cases for a 2-week period in school-age kids, there was 2,232 total cases in the Yakima County over the last 2 weeks. 557 of them were school-age kids between the ages of 5 and 18, which is 25%. Over the duration of the pandemic, usually we're in the mid-teens. So you can see where it's increased since this school year, it's increased 20%, 24%, and then this last 14-day period was 25%. The next column is the case rate in Yakima County. So you can see as of yesterday, we're at 865 cases per 100,000, where at the beginning of September, we had peaked just shy of 11,000 cases per 100,000. One thing that we're seeing is in the K through 5 grades, these are the grades that are 100% unvaccinated. We're seeing a lot higher percentage of cases in those grades. We're seeing 42%. In the past, in the pandemic, we were all over the board as far as what grades were higher or lower. Some weeks we'd see the high school grades were maybe higher, some grades the K through 5, and some grades the middle school. And so we've been consistently seeing that K through 5 grades being higher. We move down. This next section is just over the last week, a 1 week period. And so last year, the total for the whole school year, we saw 345 students that were at school while infectious. And you can see this last week, we saw just 153 in 1 week. And so far we've seen 449 total students that were at school while infectious. And then staff at school last week, we saw 33 staff members that were school while infectious for 111 total this year. Last year, we had 259 total for the whole school year. And so And then on-site transmissions. So last week we had 7 new transmissions that were actually attributed to being on on-site, actual transmission at school. Last year we saw 28 total. This year we've had 28 total this year. So right now we're matching what we had last year. Class closures, we had 3 last year. We had a total of 7 class closures this year. And then as far as athletic teams, we have 8 total athletic team where the whole team has been quarantined this year. So just wanted to bring this, just kind of explain this chart to both the Board of Health and then the public, so they can see, kind of get an idea of what's going on in the schools. Any questions on one question that's usually asked too is hospitalizations in school age kids. And then for the month of September, there has been, as of yesterday, there's been 13 hospitalizations in the age group of 0 to 19. The highest month that we'd had in the past was 5, and that was 1 month. Usually it was 4 or less hospitalizations in that 0 to 19 age group.
Brian, can you explain or maybe remind us all how many schools were actually, how many students last year were in person all the time compared to this year?
Right, yeah, and so most all the school districts were in a hybrid model. So they were either going to school a couple days out of the week, or they were going half days. And right now we are at we're at full capacity in schools, and the requirement, if possible, just need to be 3 feet apart. Where last year they were required to be 6 feet apart, which is why we had to go to that hybrid model.
And can you further explain the testing requirement if there is a positive? So what is required of schools and parents to go now and test their children if they have potentially been exposed?
All right, yeah, I'll turn that over. Melissa, did you want to address that?
There is no requirement to test your student if they are in close contact. They're put in quarantine. Some schools have implemented the test to stay, which allows you to test on day 5 or 6 of your quarantine. And if negative, you can return after 7 full days of quarantine. If you choose not to get tested, the gold standard would be to quarantine for 14 days. If that's not able to do, then you can quarantine for 10 days.
So if you test, you can go back to school sooner if you're negative?
If the school has adopted that test to stay program. Not all schools have implemented that.
Sure. So we're seeing more tests for school-aged children this year compared to last year?
I would say it's very few. I only know of 2 schools that are doing test to stay.
No,
My school district, which has 16,000 students, is not doing a test to stay program.
Sure. So we're seeing an increase in testing of school-aged children compared to last year when children were not in school full-time.
I would have to run a report to see how many tests were actually, in fact, I don't even think I have that because we don't see all of the negatives. So, I mean, that would be you'd have to look at the denominator and see how many we actually tested students last year. We don't have that because we only have positive results. We don't get notified of negatives.
Sure. Well, maybe can we pursue that and compare the tests, the number of tests administered to school-aged children last school year versus this school year?
We don't. There's no way to, DOH doesn't report the negatives are not reported through the Washington disease reporting system. We don't have access to negatives. So I have no way to know how many tests were administered on school-age kids. I only know the positives.
And do we know the population of 0 to 19-year-olds in Yakima County is approximately 30%?
I don't know that.
I think that's the most recent Census Bureau information, that approximately 30% of the population of Yakima County is 18 and under. And then hospitalization rate over the course of the pandemic, it looked like the rate was about, for 0 to 19-year-olds, a little over 0.5% of the population who's tested positive has been hospitalized in that age group 0 to 19, and 0 deaths. Is that correct?
So I'll speak more. I have some slides that I'll be able to show you, some graphs that look at the FB on that when I give my report.
Perfect. Great. Thank you.
Okay, any other questions on? Oh, go ahead, Mayor Breyer.
Thank you. I have a list of questions people have asked me to ask today, and I'm going to actually do that under new business so they can be answered later. But this does raise a question, because somebody asked how many people are actually tested. So we have the negative test versus the positive tests. And I'm very curious to know why we're not asking the information about how many people are being tested totally, to give us an idea of how many people are being tested and, you know, what percentage of those are positive and what percentage of those are negative.
We are able to see how many over a week's time or a daily when they send the epidemiology report, how many positives and how many negatives, but it doesn't break it down by age. DOH just gives us the amount. So we can estimate an actual positivity rate, but we can't break it down by age, unfortunately, with the data that we're given.
Mayor Byers, one of the complexities, oh, I'm sorry, ma'am.
No, well, they want to know specifically how they can, and even if it's not by age, how they can get, where they can find the information on positivity rate.
Well, we do keep, oh, I'm sorry, Lillian, do you want to answer that?
Yeah, just really quickly, we do have an extensive page on our website that has a dashboard where you can look at all of this information. And I'm happy we can do some more messaging just to remind people about how to navigate that dashboard as we've gotten vaccines and testing, epidemiology curves, demographics. There's a wealth of information. So I'll definitely work on getting more communication out so people know how they can get in there themselves, really at any point in time, to look at a wider range of data.
Thank you.
At the state level and at the county level.
Great, thank you.
And Commissioner Byers, at a very raw level, we know how many tests were administered at the testing sites, but that doesn't correlate to how many tests are totally done in Yakima each day.
So what you would provide then, Lillian, would be from the testing site, is that correct?
The dashboard that I'm referencing is essentially all of the disease reporting system data available in Washington State. Then you can break it down by county. So I do that for fun sometimes. I like to look at how does Yakima compare to other counties because I like data. But you can look at testing, vaccination, demographics, hospitalizations. You can look at how the trends have changed over time. There's essentially several different buttons that you can click on and off to look at exactly what you'd like to see. So I'll put that together for the board, just some quick highlights, and then we'll also make sure to do some more messaging around that this week and to remind people about that tool.
Appreciate that.
Any other questions?
Just a quick one, maybe for Melissa, just so I'm clear. Nobody is collecting an accurate denominator of number of tests being given. Is that correct, Melissa, or is that consistent with the statement that you made?
They're collecting the actual denominator, but it's not being, when I pull up the Washington Disease Reporting System, I can only see positive cases. So I have no idea, if somebody's negative, I'm not going to find them. It just means either they weren't tested or they're negative. The DOH has that information, but I know that a lot of times they're doing data dumping because they've just overloaded the system. So they tell us the denominator for the whole age bracket, but not individual brackets. Which is how they come up with our positivity rate on the EPI reports.
Any other questions?
Okay. All right, thank you, Jocelyn. You can take that off the screen now. And the only other thing that I want to add is that we do have 2 temporary positions that we are currently advertising for. That is for an office technician position and a public health technician position.
Okay,
That's all I have.
thank you. We'll move on now to emergency response coordinator, Nathan.
All right, good morning, everybody. So we'll start with testing. So we have the 2 community-based test sites, the one at Sunnyside Community Center and then the one at Yakima Valley Community College. Both are staffed by partners and contracted through University of Washington Lab. We've worked with them to adjust some days. So we now have a 7-day-a-week coverage. So the Yakima site is open Tuesday through Saturday, and the Sunnyside site is open Sunday through Thursday. So we have 7-day-a-week coverage community sites in the county. We are experiencing extremely high levels of testing at both sites. The Sunnyside site is clearing over 200 tests a day, and the Yakima College site is clearing over 600 tests routinely. a day. So with that and the anticipation of more testing coming up as the October 18th vaccine mandate rolls around, and certainly as we get further into cold and flu season and more people experiencing symptoms and wanting to get tested to see if it's flu or if it's COVID, we're anticipating a need to increase our testing capacity within Yakima County. Also to help take the load off of our hospitals and healthcare system that are extremely busy as it is right now. So with that, we are bringing back a community-based drive-through test site at the State Fair Park. We will be over the next several weeks building that out. It will be in partnership with Columbia Safety, who will be staffing it. We're really looking at what the days and hours are looking at, or what they will be. But it will be a 5-day operation, and the goal is to have that open no later than October 18th. So I will be working with University of Washington Lab, the Central Washington State Fair Park, and Columbia Safety to get all the pieces together to have that site go live by October 18th.
Thank you.
And just to be clear, Nate, question I get all the time from people in the community. What is the gold standard test that you're using at those sites? Is it a antigen test? Is it a rapid test? Or is it the PCR test?
These are the PCR tests. And they actually, we work with, they go to University of Washington Lab, and we also utilize their courier service. So every day they have a courier that comes, picks up those samples, drives them over to the lab. So we get a pretty quick turnaround on those results as well.
What is quick, Nathan? Is it 2 days, 3 days?
It's max 3 days. It's typically within 2 days though.
And Nathan, do they keep track of the negative and the positive?
So with the 2 sites right now, we do have that data for our community sites. We'll be trying to build that out for this 3rd site as well. There's just some complexities that we need to build out as we put the site in place.
Okay, thank you. Anything else, Nathan?
Yes. So with vaccines, we've done some tailoring to our vaccine teams. We used to have 2 teams that were 8 members per team. We've trimmed those down to 6 members per team and have been able to add an additional team with that. So we have 3 teams of 6 staff members, and they are now also pushing the boosters that have been approved. And we're really working very closely with Columbia Safety to be looking at long-term plans and planning out for additional approvals that come through the FDA and ACIP on boosters or the K through 12 vaccines. Just this week, the FDA or Pfizer submitted data to the FDA for approval for K through 12 K through 12 kids to get vaccinated. So we know that those approvals will be coming down the road. So we're really trying to position ourselves to where we can be very nimble and respond to the community's needs as those approvals come through. So we're working with that as well. So with that though, other than that, we continue really just ensuring that we have adequate testing capacity and adequate vaccine capacity within the county as we navigate these next several months. That's all I have. If there's any questions.
Any questions for Nathan?
I don't necessarily have a question. I just have a request for the community-based drive-through testing. If we can make sure that there is at least a day where we have later testing availability for people that can't be there during the day or have trouble finding a ride to get testing. I think it's very important that there's a wide variety of times.
No, I think that's, thank you for that comment. And we have tailored the Sunnyside site to add a evening. So on Tuesdays, they operate from 12 to 6, whereas the rest of the week they're operating 9 to 3. We are planning to have at least one evening option similar to that 12 to 6 hours at the State Fair Park as well. Also including one of the weekend days. So we know that the college site is operating Tuesday through Saturday. So we're anticipating that this site will run Sunday through Thursday. That would give us 7-day-a-week coverage within the city of Yakima. And then certainly we would still have the Sunnyside site operational. So
Thank you. Anything else for Nathan? Okay, we will move on then to our health officer, Dr. Berg.
Good morning. It's again a privilege to be speaking to both the rest of the people I'm working with and to the board. And I would like to add, I've been doing this for about 2 months now, and I think we're very lucky to have a crew that works as well as our health district folks. And I'd also like to extend kudos to the board for their very insightful questions about the budget and testing. Melissa can correct me, but I think there's 2 numbers that have been generated. It's the number of positives per 100,000, which gives you a good idea of the number of tests being done and the number of positives. So it's not the exact numbers. And those are numbers that were used for the various stages that the DOH did for opening things up last year. The other data that's collected is the percent positives, which we've been talking about during the morning. So I'd like to take the opportunity to work backwards again from the hospital data back to the community like I did last time. But I just want to review things really quick. If we start at the hospital, everybody appreciates how busy it is and how hard it is for all the nurses and doctors to be dealing with all the problems. So that's still present and may be decreasing slightly. The options in the hospital, besides supportive care, are to administer a drug called remdesivir, which is an antiviral. And just talking with Memorial people, it's costing the hospital $200,000 a month or $2,400,000 a year to administer the remdesivir. There's another drug called Paracetamol, which is given later on during the course of serious illness. It's a monoclonal antibody, and right now it's free. But when we have to start paying for it, my guess is going to be $1,000 or more per patient, maybe as much as $5,000 per patient. They're generally very expensive. So moving into the ER, which we know is busy, at this point, the patients may be critically ill or they may be mildly ill. And just before the ER, there's an opportunity to intervene again with a medication. That's the monoclonal cocktail, which we now will have available. Marty put out an announcement that'll either be today or yesterday late. And we have another announcement talking about the availability of that monoclonal. What the monoclonal does, it changes the probability of hospitalization. We'll be using the subcutaneous route. And what they found in a study published in New England Journal, that if you don't get any intervention for all the people that are infected, about 7% will end up in the hospital. For those folks that show up for monoclonal antibody, that's cut down to about 3%. That may not make much difference in the city of Yakima, but statewide, if that program goes into place, there'll be a lot of beds freed up from people that don't have to go in the hospital. So moving out from the monoclonal antibody administration, we have doctors' offices who are seeing patients. And before that, we have testing. And before the testing, we have people that are ill and people that are exposed. And all these generate time and costs. And before people get sick, we have vaccination. So that was a very nice segue into a talk I actually prepared for this meeting. And I need to have my screen sharing permitted.
Dr. Barr, may I ask a question quickly?
Sure.
Can you give me the cost again of the remdesivir?
So for the courses that were given, the hospital told me it's about $200,000 a month.
Thank you.
All right. Okay, coming up. All right, so I'm going to give you a little PowerPoint about COVID vaccine and what it is and how it works. So in this short talk, we're going to cover what the facts are, how the vaccine works, how is the vaccine evaluated, what are the side effects, and what are the benefits. So nationwide, about 55% of people are vaccinated. That's including the second dose of Pfizer or Moderna or the single dose of the J&J vaccine. 40 other industrialized countries in the world have better rates than we do, which is kind of disappointing. For the Pfizer, 12 to 15-year-olds, it's still under an EUA, but it's available and coming up for approval. The 5 to 12 age group is under study and may get an EUA soon. The third dose has just been approved for people who have underlying illness, immunocompromised, or older than 65, as a few of us are. And if vaccinated, it prevents hospitalization and death in 88% of the recipients. And that is a pretty good response. The Moderna vaccine is still under EUA, but all data have been submitted for the review to FDA, and I suspect that will be approved in the next 6 to 12 weeks. This is another 2 doses, 4 weeks apart, and the third dose has the same criteria as the Pfizer once it's approved. This vaccine prevents hospitalization in 93% of the recipients, and that's why some of the data or the news reports have said this is the best vaccine. For the J&J, a single dose booster may be approved soon. And what happens if they get the second one is it prevents hospitalization in 71% of recipients. At the current time, there's an EUA for 18 years old and older. Everybody understand what the EUA is? It's a expanded access, not yet approved.
Dr. Barg, I do have one quick question. If you can go back, how are you, when you're putting this together and we're using the prevention of hospitalization? Yes, thank you. Prevents hospitalization in this particular slide, 71%. What is the time period that is being looked at for this data? Is this, for instance, the last 30 days? Is this the last 6 months? Or is this in totality of the pandemic?
This would probably be since the vaccine was introduced and used, and I think this data probably went up to August.
You think? Okay, well, so it'd be helpful if we could at least get an idea later on of the dates, because I think it's important.
What would you be looking for in that data?
So, for instance, the King County Health Dashboard shows cases, hospitalizations, and deaths going back the most recent 30 days reporting, for example, and the figure differs, pretty significantly. We're seeing the vaccinated hospitalization and the vaccinated deaths becoming closer and closer and increasing in a percentage. So right now, I think the King County dashboard shows that. And I'm just using this as an example, and maybe we can get this on but their hospitalization rate shows that fully vaccinated represent 19% so fully vaccinated are 19% for hospitalizations, and 22% of the deaths were fully vaccinated. And that's just going back over the last 30 days. So obviously the time period makes a difference, because we're seeing right now actually a death rate that's declining. Even though
I have that information in my report, Commissioner McKinney. Yes.
Okay, yeah, it's just, but the dates matter. So
the numbers are still good. So, you know, much better than unvaccinated. In fact, really the way some people talk about the pandemic now, it's primarily in the unvaccinated. Now, none of the vaccines are perfect. So hospitalization is going to occur as it has, and deaths are going to occur. The numbers are just much less than the unvaccinated. All right. So this diagram shows what happens. You can see over in the left side, somebody's getting an injection, and what's injected is this construction of a lipid coat around a messenger RNA molecule. That lipid coating is very similar to the cell membrane. So it can fuse with it like that. And once it fuses with the human cell membrane, the mRNA molecule is released into the cytoplasm, which is the inside of the cell, which is cytoplasm and nucleus. The mRNA doesn't go into the nucleus. There is no mechanism for it to do that. What that means is the mRNA can't do anything with the DNA that's part of the human cell. It is used in the protein manufacture structure, which you see here, to guide the manufacture of the spike protein. So this mRNA codes for the directions to make the spike protein. This spike protein then is transported to the cell membrane and then becomes visible to the immune system, which registers that and processes that and eventually makes antibodies. Those antibodies will then be floating around the bloodstream and available to attach to invading virus. Once the antibodies attach to the invading virus, the virus can be taken up in immune cells like lymphocytes and destroyed. That way, people are protected from severe infection. Some of this is, yeah, go ahead.
What's the time frame from the injection to the antibody?
So it's a little bit different with each of the vaccines, but generally the response to the vaccine is measurable at about 10 to 14 days. And then when you get the second vaccine, it boosts the response of the first dose so that you're fully vaccinated about 2 weeks after the second dose. So what that means is your antibody levels are high enough to prevent disease. If you're exposed before that time, your chance of getting disease is increased. Does that answer your question okay?
Yes, thank you.
Good. All right, so just a quick review. The mRNA codes for the manufacture of the coronavirus spike protein. It's taken up by the cells that are near the vaccine injection site. So the material that's injected doesn't really circulate through the body. The human cell then generates the spike protein and only the spike protein. No virus is constructed. Therefore, there's no viable virus generated from the protein coded in the vaccine. The spike protein is transported out of the cell where it's detected by the immune system, and then the immune system manufactures the antibodies directed against the spike protein. So it's just the text review of that diagram we saw. So to further review the interaction, the antibody binds to the incoming virus. So that's the antibody that the vaccine induces. The immune system recognizes the incoming virus. The virus is destroyed. Now, here's a couple points I think are worth emphasizing. The messenger RNA that's delivered by the vaccine degrades rapidly once its directions are used by the body to make the spike protein. That happens to any mRNA, ones that are made in our cell or ones that are introduced by the vaccine. The immune system remembers the response to the initial protein and can react to a new virus challenge downstream. This could be 3 weeks or 3 months. So that you remain immune to the virus for as yet an undetermined time, but it looks like 6 to 9 months for sure, and possibly longer. To repeat, there is no live virus made by the vaccine. The J&J vaccine is a little different from the Pfizer and Moderna. It's made from an attenuated strain of adenovirus, which is another common cold virus. This virus was weakened by replacing certain adenovirus genes with the COVID genes that make the spike protein. Once the spike protein is made, then it triggers the immune response very similar to the same spike protein made by the two other vaccines. The patient's protected against severe disease once again. The adenovirus does not replicate in the human body because the genes that allow it to do that have been chopped out. And therefore, it doesn't change the patient's DNA, nor do the other two vaccines. So a little bit of background, the technology about these mRNA vaccines have been around for about 2 decades. Previous attempts to use the vaccine the technology to manufacture vaccines have been used for influenza, Zika virus, rabies virus, and cytomegalovirus. However, these vaccines never made it out of the development stage. The COVID vaccine is made with the same technology, and when it was used in initial tests, it actually worked really well. So it was ready to get out of the development stage. Small trials were started to check on how it worked and to check for the side effects. And once the preliminary studies were done, which also showed they were very effective, the vaccines were brought into broader use. At this point, the mRNA vaccine had made it through the initial evaluation. What I'm going to do from this point on is show you how stringent the bringing this vaccine into widespread use. It went through very careful evaluation. And just one other point about the mRNA technology, it's been used to treat cancer by directing the immune system to attack cancer cells. And that is in use. So the preliminary information was reviewed by the FDA. They thought it looked good enough to allow a large clinical trial. Before this went in, the vaccine preparation and manufacture process was met all quality and safety standards. In the first studies, thousands of patients were enrolled, and they wanted to try and determine the safety and efficacy in those thousands of patients. It did look good. Additional studies done on more patients with continued evaluation of all the data with FDA oversight. Each phase of this evaluation was a randomized double-blind study, which means that the administration of the actual vaccine was randomized. So some patients might get it in a row, another 2 or 3 or 5 might not get it by a randomized schedule. The double-blind study means that patients and doctors did not know who got the vaccine and who got the placebo. The data was then evaluated after the administration of the vaccine in those patients. So all the data from all the studies was submitted for review. All facilities making the vaccine were inspected. And also all the data was submitted to an independent panel of experts, not at the CDC, not at the FDA. It's called the Vaccine and Related Biologic Products Advisory Committee. So the panel had recommended each vaccine for expanded use access. The FDA commissioner reviewed the data and the process and then signed off when it was satisfactory. The CDC Advisory Committee looked at the data and asked the following questions: who should be vaccinated? How many doses should be administered? How much time should elapse before the second dose? And those recommendations were approved by the director of the CDC. So that's where they came up with a Moderna frequency at 2 doses, 4 to 6 weeks apart, and the Pfizer frequency, the second dose, 3 to 6 weeks after the first dose. So at this point, after that very careful review, the vaccines were determined to be safe to use. The EUA was issued for Pfizer in December 2020, Moderna and J&J in February 2021. An EUA was recently issued for the 12 to 15-year-olds, and as of last Friday, the EUA for a third dose was issued for persons with immunocompromise and over age 65. So this one chart summarizes what I've just said, from the pre-clinical investigation down to the large scale phase 3, and then emergency use initially for healthcare workers, high risk populations, and then to the broader population. And then they also did at the same time how to make a lot of them. So this thing was very closely integrated and very closely watched. So the usual side effects are pain, redness, and swelling at the injection site, as well as fatigue, headache, muscle and joint pain, chills, and fever. So in all, this vaccine was the most closely monitored one in history. The side effects I just talked about usually occur within 2 to 3 days post-vaccine, and rarely have there been allergic reactions reported. There are some safety concerns, and I have some of them listed here. The J&J vaccine causes clots, or a syndrome called TTP, which is involved with clots and platelets. And the frequency of that's pretty low, 7 in a million doses. Another side effect is not directly related, but could be triggered. It's called Guillain-Barre, which is a immunologic disease that affects the nerves, causing an ascending paralysis. The J&J vaccine does not seem to do this any greater than multiple other vaccines that are currently in use. The RNA vaccines, the Pfizer and Moderna, are associated with myocarditis and pericarditis, and these occur in teens and young adults predominantly, and often occurs within 5 days of the vaccine. The majority of patients make complete recovery, and the incidence of this is 12.6 per 1 million. There is also severe allergic reactions called anaphylaxis, and that occurs in 4 cases per 1 million. By the way, these are all very low numbers. So the benefits of vaccination can be seen in this list here. For unvaccinated persons, they're 4.5 times more likely to get infected. They're 10 times more likely to be hospitalized, and they're 11 times more likely to die. Of every 500 infected patients, 1 has died from COVID. And this graph here shows what's going on over the course of this epidemic. And I want you to notice the 2 top lines. That's age 20 to 23, or sorry, 20 to 34. And the red line is age 35 to 49. And that's where we're seeing a lot of hospitalizations. And in Yakima County, this group is vaccinated at a much lower rate than this group. So that may be related to why we're seeing more problems with the younger age group. The vaccination rates are lower. And with that, I'd be happy.
Significant, Dr. Barg, to point out, if you could go back to that slide, that
Sure.
it appears to be the same age groups throughout the pandemic. So is it? Maybe you could clarify your last statement.
So are you saying in reference to, say, this part of the epidemic versus this part?
Sure, and even back in July of 2020, we continue to see that throughout the increases in waves, the age groups that are being hospitalized, it seems to be, tracking along the same percentage for the different age groups.
Yeah, actually, this is the new COVID rates per 100,000. So by age group. So when you have a large number of patients infected, you usually see a larger number of hospitalizations. Now, this here, I want to remind everybody, is Delta. This here is Alpha. And there is some differences in Delta and Alpha. And one of those differences, it leads to higher rates of hospitalization. So these infected people may have had a lower rate of hospitalization than this. So these are just cases, not necessarily hospitalizations, but we do know that this group here is being hospitalized at a higher frequency.
Do you
So
have
sorry
that graph
for,
that you can share?
Pardon?
Do you have that hospitalization graph that you can share?
I don't have it, sorry. I don't have one.
Well, can we look at that the next time? It would be interesting to compare the hospitalization rates and maybe we could just pull that up on the dashboard. Maybe Victoria can pull that up off the state dashboard to compare, because I know it's readily available right now.
Right. It shouldn't be hard to find at all. All right, I think that's my last slide, so I'm happy to take any questions.
Dr. Barg, I'm wondering if you can make this slide presentation available to the board.
Yeah, I think Andre already has it, so you bet.
Thank you.
We can certainly send that out. Thank you.
Any other questions or comments?
Dr. Barg, I wanted to thank you for taking a high-level science presentation and really making a very clear presentation as to the effectiveness of vaccines. And it's just so sad, really, to see that in the educated group of people, this is clear and convincing evidence of the effectiveness of vaccines. And yet, to so many people out there, they're using anecdote and Twitter to get their health advice, which is absurd. So I just commend you on delivering this data as convincing. I mean, once you make the statement that it reduces death and hospitalization, it really should end the argument as to whether or not we should be vaccinated. I mean, you know, outside of the people's choice to get vaccinated or not, the argument for vaccination is clear and convincing. And I just want to commend you on delivering pretty high level science in a PowerPoint that takes 5 minutes. So thank you for your time and effort in doing that. You're doing a great service to the people of Yakima County.
Thank you for those comments, Commissioner Atterbury.
Dr. Barg, I'd like to thank you again, and to follow up on what Dr. Atterbury said. I think it points out really well that this work was decades in the making, science and research, to allow for the very rapid process of creating a new vaccine. So if I'm not mistaken, that was called Operation Warp Speed through the previous administration. And that wouldn't have been possible had it not been for many, many, many years of research and successes in building the ability to ramp up large scale. Thank you.
If I could, I'd just also like to thank Dr. Barg for putting this together. It's very concise, and I think it can be very helpful. I appreciate the fact that you're willing to share this with us as well, because I think as questions come up, we can share this with others.
Thank you.
Thank you, Dr. Barg. That was most informative. Any other questions?
No, I did send the link to Victoria so that we could pull up and look at the hospitalization demographics by age. So she should have that link.
Mayor Byers?
Yes, thank you. So Dr. Barg, thank you. And one of the things that, you talked about the side effects and the number of people experiencing side effects. And I'm wondering if that information comes from VAERS, from the Vaccine Adversity Registration, because there is some information that maybe 10% of the actual responses to a vaccine is reported there. So would that be accurate?
Yeah, you know, the response to any sort of adverse event is always underreported. And I don't know the exact number, what goes into the adverse event database as far as how many people actually experience it. But if you look at the reports, 10% of a very large number can still be statistically significant. And most of this probably comes from the adverse event database.
Okay, so it likely is, while it comes from the database and gives us a picture, the picture might actually be larger in terms of adverse events.
Yeah, it could be, but even if it was 10 times, say 1 in a million, that's still a pretty low number.
Thank you. I just appreciate answering the question. So, and thank you for the presentation.
You're welcome.
Dr. Cleary, do you have any comments?
Yes, thank you, Dr. Barg. I appreciate that. And I was wondering if you would just comment on the use of monoclonal antibodies versus the vaccine. The vaccine seems to be aimed at teaching your body to produce an antibody that will protect you versus receiving an engineered antibody that is essentially the end product of what the vaccine would produce, but without any memory to protect you in the future.
Yeah, that's correct, Dr. Cleary. The monoclonal antibody that would be administered as basically an outpatient prior to the onset of severe illness is around the body probably for 2 to 4 weeks, and then it's gone, and no memory response is present after that. And as stated, the vaccine would be cheap if it was not free now, and the monoclonal will not be cheap once the EUA period is over. And its effectiveness, of course, is much less than the vaccine. So it's a stopgap. It's an intermediate way of dealing with the infection.
Dr. Bargett, it has been highly successful in Florida and Texas, and I understand the Biden administration is now moving to take control over disbursement of the monoclonal antibodies, which you and I have discussed the reason why it's become, difficult to get our hands on a large supply of it. And I'm really pleased to see that we're having this treatment finally available in our community. But I'm just wondering, my understanding was that some of these, the previous administration had made sure that the monoclonal antibodies treatment was going to be free. And so you're saying there's a cost. So what is the criteria that moves us from being able to get this from the federal government at no cost versus when it's going to cost funds? I'm not familiar with the status of why it would change.
Yeah, so if we go back to remdesivir, when that initially became available, the government bought many doses from the company and distributed that to the states, and the states distributed to the counties in a similar way that the monoclonal antibodies are now being distributed. And then I guess that supply ran out. I don't know if there's a time limit related to this or a particular number of people that would get treated, but we now have to pay for remdesivir. And I guess in the future, if this becomes an attractive alternative, that eventually this will have to be paid for as well.
So the previous administration paid for it. So the current administration could likewise determine that it was going to purchase this to benefit the public as well.
Yes, this monoclonal cocktail has been purchased by the government, who is now distributing it. And by the way, we have a certain number of doses in town, and we'll get more doses once these are used. But it would be great if the board could advocate for the monoclonal cocktail for use in Yakima County.
That's what we're trying to do. So I just want to make it clear then, the cost then could be deferred by the federal government if the current administration determined it wanted to do what the previous administration did, which is to purchase these treatments for the public at no cost.
But that's what's happening right now. But as with remdesivir, that support from the government ran out at it was a finite number of months, and it might happen with the monoclonal cocktail as well.
So they ran out of the supply that was purchased by the previous administration.
Correct.
Okay.
So I'm wondering at this point if it's appropriate to suggest that at our next meeting that we have type of a letter put together by the board to advocate for ongoing monoclonal antibody being provided by the federal government.
I definitely supported that.
Yep.
I might add too, we already said it today, but I'll say it once again. The effect of this monoclonal antibody is much less than the effect of getting vaccinated, and the effect of vaccination in a certain population is much better than administration of this monoclonal antibody cocktail to the same population.
And I think the other limitation is that monoclonal antibody therapy is only available to a very limited number of patients, those that present in very short order and have only moderate symptoms. And I don't think it's approved for under 18, so children would not be able to receive it.
Yeah, Dr. Clear, there's also a guideline issued from the NIH. It's a qualification questionnaire, and it has all of that information, those questions in it. So not everybody that comes to get it actually will if they don't meet the criteria. The most important of those criteria is the high-risk patient who is highly likely to be hospitalized if the COVID infection proceeds.
I do also like to share, if I may, that it's a labor-intensive application, so that people have to be watched. I know you can speak to that better than I can, Dr. Barr, but also it is in short supply. Really, one of the utilities of vaccination is that the goal is not to get sick in the first place.
Councilwoman Duval, we haven't heard from you for a while. Do you have anything you would like to add?
Not at this time. I'm just receiving the information. And again, thank you for providing it in such a clear and concise way.
You're welcome.
Would Victoria be able, since we've got this slide up, to pull up the age demographics for hospitalizations that was sent? Just as to look at, so we've got here the positivity by age, and then if we could compare that to the hospitalization by age.
Jocelyn, we'll have to pull down the screen or the screenshot now that we have.
Oh, I think Dr. Bard will have to stop sharing his screen first.
Commissioner Lindy.
Yes, if I could, just a quick comment and a question. When I was working at the Sunnyside Hospital last year, I do recall that when remdesivir first came, it was available at no cost, but a few months afterwards, when it actually, the hospitals were charged for it and became quite expensive after that. But on the Dr. Barr, just a quick thing, when we talk about the effectiveness of a vaccine, for example, an 88% effectiveness rate or 93% effectiveness rate, we're talking about the fact that it's 93% effective against someone who's actually contracted the disease, correct?
I'm not sure I've followed that. Do you mean to say that?
So, okay, let me try that again. So Moderna, for example, is supposed to be 93% effective against hospitalization or death in those who've received that vaccine. Now, I'm assuming that means it's 93% effective for those vaccine recipients if they've been exposed to the disease or contracted the disease. Is that correct?
Yes, that would be correct. So just to clarify, the vaccine prevents infection in the large number of folks, and then some folks will get hospitalized. So severe infection is prevented, and in a very small number, they'll actually proceed and get seriously ill and die. But that number is very small and better than many other vaccines that we have for treating vaccine preventable illness.
Thank you.
Just for the meeting awareness, I do have that graph pulled up that's similar to the case rate.
So if you go, Sean, to demographics.
Yeah, I have it pulled up. I know the exact one you're talking about. So I can share my screen if Jocelyn hasn't found it yet. One second.
Okay. That up. Just another thing that I wanted to request was if we can have Dr. Barge, his presentation be translated in Spanish and provided to our Spanish-speaking community.
Yes, we can definitely do that. We have one of our local doctors do that in Spanish, and we can re-record that. Thank you.
Great, thank you.
Okay, can everybody see my screen?
Yes.
Okay, so this is the graph for Yakima County trend and 7-day rate of new COVID hospitalizations per 100,000 population by age group.
Very similar.
Indeed.
All right, well, if you'll make these available to everybody, that would be appreciated. We need
I'm sorry, could we request, Dr. Barg, that you add this slide next to your other slide for hospitalization rates so we could also see, excuse me, the test positivity so that we could also see who's being hospitalized?
Yeah, sure. If they just send me the slide there, I can drop it in real easy.
I'll send you the link, Dr. Barth.
Good.
All right. We do need to move on. We have some other reports and new business to contend with. So if everybody's okay, we'll move on next to Melissa of Sixbury.
Okay, hello, everyone. We currently still have 6 active TB cases that we're monitoring. So no new ones since our last meeting. We have started our influenza surveillance. So all 3 hospitals will report their positive and negative influenza results to us so we can have an idea of what's going on within the community. Hopefully we'll have a mild season again this year, given the mask mandate, which will help keep our influenza numbers down. We also, with the loss of the funding from the Department of Health for our outbreak team, switching that over to YHD employees, we went from 9 outbreak or health service consultants down to 3.5. And so we just hired 2 additional ones. Most of the team took positions with the Department of Health or moved on to grad school. So we did just have 2 new ones. One started last week and one started this week, and they're doing a great job. They're helping with long-term care and our school outbreaks that are going on. As Ryan mentioned, we are seeing an increase in our school cases. One thing to note, in the 3 classroom closures that we've had this week, 2 of them were from special education classrooms. These classrooms are students who cannot wear masks, so it just confirms that mask usage does help because it's spreading in these classrooms where students cannot wear masks. Over 50% of our classroom closures last year were in special education classrooms where masking was not done. And then I have some slides. Jocelyn, if you'll pull those up. And next slide. Okay, so this is going to kind of demonstrate some new weekly data that we'll be putting on our sit reps and our web pages to kind of show trends in hospitalizations, breakthrough cases, et cetera. Next slide. Go ahead and go to the next one. These are just the same slides, but I think the next one, oh, sorry, go back one. Okay, so this kind of breaks down into a table format instead of a line graph, but it does look at the hospitalizations by age group from the beginning of this pandemic up through, I believe, the 22nd. So you can see, like Brian mentioned earlier, the reason why some of these are in red is because every day when our epidemiologist updates these numbers, she highlights in red for anything that data that has changed. So you can see that for 0 to 11, we've had 25 total hospitalizations. 12 to 19, we've had 25 hospitalizations. Most alarming is that 13 of those have been in September, which is much higher than any other month we've seen, which previously was July of 2020. So we are seeing an increase in our hospitalized 0 to 19 age group. You can also see in your total column that we are already at 200. I believe this was from Thursday's numbers. So from the 22nd or 23rd, so we still had, plus with the lag, this will continue and very well potentially could surpass what we saw in previous high numbers, which was 234.
Melissa, I just want to say thank you. I'd asked for this to be included on the situation report because I do think it paints a very clear picture of who's actually being hospitalized and the age groups similar to our test positivity. So I just appreciate it because it really does make it a lot easier to understand who is actually being hospitalized at a higher rate, both pre and post vaccination.
Thank you. Next slide. This one looks at our hospitalizations among fully vaccinated and unvaccinated. So for COVID cases, 7% of our cases from January to September, 7% were fully vaccinated. 93% of our cases have been unvaccinated. And then we picked January because that was when the vaccine was first out, excluding the 2 weeks in December that we had it, but it takes, January is when we had the first set of fully vaccinated people. For our hospitalizations, from January to September, 7% have been fully vaccinated. And as you said earlier, Commissioner McKinney, we are seeing from the last month an increase in hospitalizations of those that are fully vaccinated. It's gone from 7% since January to 16% of those fully vaccinated are hospitalized, but still shows the, this is mostly probably due to the Delta variant, which seems to make people a little bit sicker. And it's also, we're having a higher breakthrough cases due to the Delta variant. So that's a contributing factor to that as well.
Melissa, is there a way, this is wonderful, and the King County Health Department has had this information up on their dashboard. They also, though, put the raw data. Could I ask that we do that as well? Because and I know that how you do it, and there might be a little bit different. They would be great to ask, but you're able to look even past the 30-day. They post the raw data for the last 30 days, which shows, for example, the death rate in King County, for the last 30 days is less than 0.5% for the vaccinated. And it is about 0.75%, so 0.75% for the unvaccinated. So you can actually calculate the current death rate over the last 30 days versus vaccinated, unvaccinated. I think it'd be really helpful if we could do the same thing.
Okay, so I'll talk to Andre and Ryan and our epidemiologists and see how we can make that most presentable and looking at raw data versus graphs. But yeah, we can.
They have them both. I think the graph's great. They also insert the raw data as well. So it'd be great to have both.
Yep, I'll talk to our epidemiologist and see how easily she can do that. Next slide. This looks at our breakthrough cases from over age brackets, and you can see the highest age bracket for breakthrough cases is our 30 to 49-year group. Could be several things. We expect breakthrough cases. This vaccine isn't 100% effective, but it is doing a great job at keeping people out of the hospitalized and severe disease. Some of this contributing factors could be the behavioral changes in individuals in this age bracket. This age bracket tends to do more social functions. It's your working population. So those could be contributing factors. And there's been research articles out that have talked about that your younger group that has more socializing events, they're going to sporting activities, that they're going to have more exposure. So the idea is that the more exposures you have, the increased risk you have for a breakthrough case. Next slide, please.
Melissa, can I interject here for just a second, if I may? So again, thank you, along with Commissioner McKinney, for the graphs are very helpful, but I also like raw data. So if we can get raw data to accompany the graphs, I would appreciate that. Also, it's interesting to me that the age group we're talking about, because we have a 65% essential workforce in Yakima, we have from the beginning, and those people have been working, those essential people from the beginning. I think we're seeing a lot of the same trends age-wise, simply because we have such an extensive amount of essential workers.
Agreed. Thank you. Okay, next slide. Okay, so this one just kind of points out our deaths by age group. So the concerning thing on here is this 35 to 49 is taking the orange line there, is taking kind of a huge increase from what we saw previous months. And then also the yellow, which is the 50 to 64, is a sharp incline. And it's reflective of what we're seeing in the hospitals. But we are seeing our average age of death is still mid-60s, but we are seeing it now dropping from a lower age range all the way down to 30 years old.
This must be state data because we don't have any deaths. Is this state or Yakima?
This is Yakima.
Okay, so the purple, your colors are different than the state. Got it. Okay. Different colors for different age groups.
Yeah, sorry. So yeah, this is specific to Yakima County, our internal line list.
And Melissa, just to clarify, that this data is not risk stratified, right? So, I mean, we don't know the morbidity that the people in these age groups carry other than the risk stratification that you would expect by age, meaning that the people might in fact be sicker that are being hospitalized that are vaccinated than the general population would be.
Correct. We have on our webpage, we do put it in the SIRIP for underlying health conditions. Because of the small age bracket, when you get down into these younger ages, it's really hard because of HIPAA to be able to say if they have comorbidities or not. But I can tell you anecdotally that these, when I review these deaths, many of them have just minor comorbidities. We're talking a BMI of 32, and they're getting classified as obese as a comorbidity, which is, as you know, is not a 600-pound male. So it seems that they're getting sicker and less comorbidities or less severe comorbidities with this Delta variant.
Dr. Atterbury, if I may as well, what we were seeing at the beginning of this response a year ago were really deaths in our eldest population. That's changed dramatically. We've seen in September more deaths, so we want to bring that to your attention and certainly to the public's attention. And also the fact, the correlation that not only is the Delta variant more virulent, more easy to catch, but also because we don't have as many people vaccinated as our community as is possible, there is more spread. And so we really are all endangered by the fact that we are a freer society now. We have more people going out, but those people can share that illness more freely. Thank you.
And next slide. Yeah, this is probably the most dramatic one that the slide that I have on here. This shows back from January where we were at with our deaths. And just for September, and we still have several days to go. And with a lag, this is going to increase even more. I imagine it's going to surpass 50. In fact, I've already got 2 today that I have to reconcile. So this just shows we are having a huge amount of deaths in September. Our census is dropping. What we're seeing dropping in our hospitalizations. So the census being how many total hospitalized patients we have on that day in those hospitals. But when you start looking at all the deaths, that's a contributing factor to why our hospital currently hospitalized is decreasing. These people are no longer occupying beds because they're deceased.
And what is the age group, if you can just give us an idea? It seems, and I know that there's also a similar graph that we were looking at, the age groups for the deaths though. Could you just give us a little anecdotal commentary on the age group?
I would say most of them are 30s to 60s, most being in their 50s. But that's anecdotally, I would have to go back and look for that data, unless my epidemiologist is listening and can send me the message.
We can send that to the board subsequently.
I think I actually had broken down it from 9/16 to 9/23. There were no new deaths for 0 to 19 known for 2020 to 29, 2 new deaths for 30 to 39, 0 for 40 to 49, 4 for 50 to 59, 7 for 60 to 69, and 5 for 70 to 79, 3 for 80 plus. So there were 21 that was just for that week, but that was the breakdown just for that week from the 16th to the 23rd. So the majority of them being over 60.
So
Any other comments? Go ahead.
I think that we've all known that the older the population, the more comorbidities, which aligns with higher risk of death. But what we are seeing, and Dr. Barr can contest to this as well, what we're seeing in the hospitals is sicker patients in the younger population, where we didn't see deaths, in our 30-year-olds or 40-year-olds. It was always, 70 plus, 65 plus, and we are seeing it more and more now, which is a concern.
Yeah, so the absolute number of deaths isn't as high in the younger population as it is in the older population, but compared to 6 months ago, there are more younger population problems than there were now, where the younger population is having a rate of problems higher than the previous, but the old folks still outweigh the younger folks with problems.
Anything further, Melissa?
Nope, that's all for me, unless there's other questions.
Any further questions for Melissa?
Thanks. It's a lot of data and it's really appreciated, but it
Yeah.
does help provide some clarity, I think, and these graphs are helpful because not everyone does like raw data. So I just really appreciative of you providing the graphs and then also willing to do the work of getting the raw data. It's really appreciated.
I can't take all the credit. Thank you to our epidemiologist, Dr. Barrios, and Jocelyn and Stephanie, our community health specialists, for helping put this together.
Thank you. Okay, then we'll move on to Mr. Sean McGee.
Oh, good morning,
Morning, Jocelyn, can you stop sharing your screen so I can share mine? Thank you. There we go. Okay, so at the last meeting, a couple members of the board asked me to give a little more in-depth presentation on the Lower Yakima Valley Groundwater Management Plan, commonly referred to as the GWAMA, which stands for Groundwater Management Area. So this is still going to be a high-level overview of what this is all about. If any members of the board would like to go into more detail, get specific documents regarding the goals, the functions of GWAMA, and what the goals are and where we're at, I can certainly send you that information, and certainly have conversations going into far more detail than what we'll see in today's presentation. So let's jump into it. So this group is called the Groundwater Advisory Committee, also known as the GWAC. We love acronyms in government, so bear with me. There are a very diverse group of partners working on this in these advisory committee meetings. This group was formed in 2012, and the goal of this group was to discuss potential problems, solutions, and different strategies on how to have a positive effect on the groundwater management area. So in this group of partners, I'll move on to the next slide because it takes up two. We have community representatives, concerned citizens, private industry, Yakima Nation, local agencies, state agencies, and even federal. So this is a big collaborative of many different agencies, individuals, companies, and industries coming together to talk about the issues that are going on in the GWAMA. So looking at these issues, the primary concern is there is a higher percentage of wells in the Lower Yakima Valley that are showing higher concentrations of nitrates in groundwater. About 21% of those wells are having nitrate concentrations above the safe drinking water standard of 10 milligrams per liter. So this, as some of you may know, I always butcher the pronunciation, but hemoglobin anemia or blue baby syndrome is the outcome of having too high of a nitrate concentration in the blood. So it is a cause for concern. I will add, though, that it is a reportable condition to the Yakima Health District, and we haven't had a single case be reported last time that I was told. So our concern is addressing the high concentrations of nitrates in groundwater in the groundwater management area. The process up till a few months ago has been the advisory committee would meet about every 2 weeks for the most part. There would be some meetings that didn't happen due to holidays and those types of situations. But again, it's to discuss all the different members' concerns, entertain possible solutions, review research data, what are implementation strategies that are viable into helping this cause and bringing more safe drinking water to the Lower Yakima Valley and its residents. The goal, the overarching goal here is to find and implement effective methods to mitigate and reduce the concentrations of nitrates in the groundwater inside the GWAMA. So with that in mind, here is a map of the GWAMA. It's a pretty extensive area of Yakima County. It spans from the southern edge of Union Gap, borders the Yakima Nation, and basically goes right down the I-82 corridor
to the Yakima Benton County line, and then wraps around south of the southeast of the Yakima Nation border. So it's a pretty extensive area. It's pretty much encompasses the highest populated area, all of lower Yakima Valley. So there's a lot of residents down here. There's a lot of water systems, a lot of wells. There's a lot of septic systems. There's a lot of agriculture. So we have to look at all these things that are playing a factor in contributing nitrates into the ground, and also look at methods of how do we lower that and mitigate, the increase of those concentrations. So this is the area we're working with. Where we're at now is the Groundwater Advisory Committee. We're not having the advisory committee meetings anymore. There has been the Lower Yakima Valley Groundwater Implementation Plan has been adopted by the GWAC. Also, there is a final order by Washington State Environmental and Land Use Hearing Office to carry out this implementation plan, that it's valid. And its goal is to mitigate the nitrate concentrations below Safe Drinking Water Act standards of 10 milligrams per liter. Also, FYI, that's the standard, where the limit is safe versus unsafe. We do have a trigger level of 5 milligrams per liter. That's where we say, okay, we're paying attention. This is starting to approach unsafe levels. What can we do to mitigate that to get below 5 milligrams per liter? So that's the trigger. Okay, we're seeing a potential issue here. We have to do some things to help get that concentration even lower. So what this plan entails is there's a GWAMA implementation committee. Listed here are the members of that committee. We do have some local agencies, including the Health District, Yakima County, South Yakima Conservation, and we are working in partnership with quite a few state agencies as well. So what our goal is to actually secure funding to carry out many different implementation strategies that would help reduce nitrates going into the ground, and in turn reduce the concentration levels over time. So some examples of what we're working on, what the health district's role in all this is, we're working in collaboration. We're not a lead agency. It's a group effort. So funding that is secured, we don't necessarily have to secure the funding for the items that we've been deemed as subject matter experts in. The funding can be shared. The goal is that it's fluid and it can be used to implement the most effective strategies first. But to give some examples of what the health district is working on for the implementation plan is looking at potential nitrate contamination attributed to improperly installed or located septic systems. There's a lot of shallow hand dug wells down there before a lot of the well construction standards went into place. So there's a lot of septic system drain fields sitting really close to shallow wells or located in such a way that they could have an effect on a shallow aquifer. There's during certain times of the year, groundwater can be a matter of a couple feet down in these areas, so easily could be influenced by improperly installed and placed septic system. Also looking at what nitrogen reducing technologies are out there for septic systems. They are expensive, they are complicated, and require ongoing maintenance. So naturally, funding is a big to do in that arena, but it is something we are exploring and something that we believe would be very effective. Also expanding public utilities in and around towns, cities in Lower Valley. Again, it's a funding issue, but that would have the most, a very dramatic effect as well. We're also looking at water monitoring and for groundwater monitoring wells. There are several monitoring wells placed throughout the Guama, as well as permission and access to a lot of private residents, individual wells for nitrate monitoring. So we are looking at implementing that to see the trends of nitrate concentrations in groundwater over time. So as we implement more mitigation measures, we can get an idea, is this working? Are we heading in the right direction? Again, that's staff and funding, which we are actively working on in collaboration with these committee members, talking to legislature, federal entities to secure funding for these projects.
Sean, let me ask you a quick question.
Yeah.
Is the suggestion or is the thought process, or do you have any data on whether or not this is a septic system problem from a community standard, or the industrial dairy septic and cow waste and fertilizer usage down in the lower valley? Can you give us any kind of breakdown of what percentages we're talking about? Because I would imagine it's much larger in the industrial side than it is in the home-based septic system side.
Right. I don't have those percentages in front of me. I'm happy to gather that data and send it to you, or all members of the board. But one of the items on here is permitting and monitoring of composting operations that include manure produced from dairies. So it is a contributing factor, and it is something that is planned to be monitored and controlled, having a set standard on how that process is carried out. And there is state regulations on those composting processes. So that is something that is the goal is to be implemented by this plan. So.
Dr. Atterbury, sorry, Sean, if I could just comment on the question, that there have been obviously many studies, and so there is no clear study that says that the dairies are the sole source of nitrate contamination. There are naturally occurring high nitrate areas, and obviously there are, going back 100 years of agricultural use of land and certain organics or whatever the growers were applying to their crops and to their fields, which are no longer in use. And then, as you stated, there is a known fact that placing wells near septic systems has determined to be a high contributor. Those were things that were not regulated on a lot of these properties going back when these wells were drilled pre-regulation, going back, even pre-1960s. And so wells that are not properly capped and that are placed too close to a drain field, which also probably is defunct, is a high contributing factor. And so much so that in order to obtain financing for real estate, residential real estate, both USDA, VA, and FHA require a certain distance be required between a septic and a well existing to obtain financing, because it is known to contaminate. So there are a myriad of reasons, which is why there was this group put together to really monitor and study to try to determine, is this a problem that is expanding, or is it based off things that were done in the past? Because there really is no way to put a finite point on it's one thing or the other at this point.
Yeah. So, go ahead, Commissioner Libby.
Sean, yeah, if you wouldn't mind, just because I have some personal experience with this, that for about 25 years now, dairy farms have had to produce a farm plan, which basically shows that if they are growing a certain crop on their property, they have what's called an agronomic rate. So they know that the amount of the organic fertilizer they can use from their farms to apply on there correctly, so it does not contribute to a problem. So.
Right. Thank you for that info.
Yeah.
Yeah. So
Sean, if I may, so we talked about one of the resolutions is to start bringing the development of infrastructure into areas that are reliant upon septics right now in various parts of the county. And I know that, with the federal monies, being allocated now and things being looked at, there are large amounts of money available for infrastructure. And I'm sure that, you as the Board of Health and the partners, and I'm hoping the county with them together are all looking to work with not only our local legislators, but our federal legislators as well, to bring some of the infrastructure money in specifically for this particular issue.
Actually, thank you for bringing it up. Mayor Byers, I wanted to share that we've been working for years, since 2012, on this plan, but also we were working with the Yakima Valley Conference of Governments on this very issue. The idea was that as a county, we recognize not only are there issues with nitrates and there are concerns about contamination, but also the recognition, as Sean indicated, that the rules around things like septics and setbacks were very different 50 years ago. And so we have smaller communities, rural communities, communities that don't have access readily to funds, that have to come up with a long-term strategy to protect not only the land, but also their community members. And so the idea was to work collectively to come up with best practices that could then be applied to each and every community. Because these issues of shallow wells or wells that are failing are in every one of our cities and towns. So that was the plan. I think that was something that was going to be addressed over the next 2 years in terms of starting to receive funding for that. And of course, that changed during COVID, but that is the long-term strategy. Thank you.
Thank you.
So yeah, and that was my next point is, COVID slowed things down a little bit. We are, last slide. We are where we're at now is we're ramping back up with the implementation committee. We had a meeting 2 weeks ago. We're meeting twice in October to discuss presentations to legislative members for funding to see what we can secure and carry out with various implementation strategies. So it's kind of a seek out funding phase right now for the implementation committee, so we can start taking action on the items identified in the implementation plan. So for the sake of time, I know we're running out. I'll stop there. Again, any more information that any of you need, I'm happy to provide that to you. If there are any more quick questions, I could try to answer them.
Thank you, Commissioner Lindy.
Yeah, I just wanted to follow up on something I think you said earlier in your presentation, Sean. And this statement is not meant to imply that we don't want to take care of our drinking water or our water supply, but the big risk that's always been outlined about high nitrate levels has been blue baby syndrome. But yet I think I heard you say that we've never had a reported case of blue baby syndrome. Is that right?
That's correct. It's more that the potential risk is still there.
Yeah.
The risk is still there.
All right. Thank you.
Any other questions?
I'll just follow up and say that, yes, it is our previous health officer, Dr. Chris Spitters, made that mandated reportable for Yakima County for any hospitals to report any babies with blue baby syndrome. And we monitor those, and we haven't had any cases reported to us.
Okay. Anything else? We'll move on then to our last report is Lillian Bravo.
Thank you. So I'll have two updates for the board. The first being around our immunization clinics. So in the past, for those current and previous board members, we have partnered with different school districts to conduct flu clinics in the past at the different schools. This year, of course, given the fact that we know that many children fell behind on their routine immunization schedule because school was out of session and most weren't in person. And as well as now that the COVID-19 vaccine is available, we're also partnering with these same school districts and other community-based organizations and early learning centers to provide not only the flu vaccine, but the COVID-19 vaccine and routine immunizations to those that are eligible for it. So we're doing that work now and through the winter. Some of those partners are Swafford and Halma, Yakima Valley Farm Workers Clinic, and Yakima Neighborhood Health Services to provide those immunizations. because of course through the Yakima Health District, we are only able to provide with the work of Columbia Safety the COVID-19 vaccine. But again, we want to make sure that the flu and other routine immunizations are available so that we can help stop the spread of other infectious diseases as well. So one big event, if you all are going to the fair, we do have a booth at the fair. We'll be there the entire time we've been there. We are providing, again, the same thing, COVID-19 vaccines, routine immunizations, and flu vaccines. And for that booth specifically, we're working with Howard's Drug, as well as Pacific Northwest University's Yakima Valley Interprofessional Education Alliance, which is YVIPEC. So at that booth, we have the immunizations available, we have health educators available, and it's also an opportunity for the students to learn. We have nursing, medical, and pharmacy students available and on site to work with the medical professionals and get experience for their future career. So it's a great collaboration opportunity. If you haven't gone or are going again, definitely stop by and say hi to the team there. They're doing a lot of great work. For the Developmental Disabilities Program, just for quick context, as part of the Developmental Disabilities Program, there is a section dedicated to employment. Through that employment program, we have several service types that are available to individuals with developmental disabilities to gain employment and support for employment. And that's provided through subcontracts with the Yakima Health District. Unfortunately, one of our subcontractors, Yakima Specialties, will no longer be providing one of these service types, which is group supported employment. But what we're doing is making sure that we can get information available to those 30 individuals that will no longer have services by providing webinars, brochures, and information. So the goal is to make sure that even though this service type is no longer available, that we give everyone the information needed so they can make a choice for a different employment provider in the future. So just some news within that program that I wanted you all to be aware of.
Lillian, I'm sorry, could I think Nyla maybe is, she typed a question into the chat box, and so I just wanted to read it. I think maybe she's not able to ask, and so she wanted to know, where at the fair are you located?
You know, I don't have the exact stall number, but I'm happy to share that out. And
is it inside the Sundome?
I wouldn't be able to answer, to be completely honest.
I thought it was. Mayor Byers is nodding yes. I believe, Nyla, that it's inside the Sundome. But I just want to make sure that that question got answered. And then could you speak, going back then, when you're talking about offering all the vaccines within the schools, you know, what kind of information and are you disseminating to students specifically? Are you providing information to students, or are you providing information to the parents? What's the communication piece?
Yes, so all of that's going through the parents. So it's the same process that would go with any flu or other routine immunizations. The information always goes to the parents, as the parent's the only one that can authorize any type of service, vaccine, or otherwise to be provided to the student. So completely the same as previous years, parents getting that information first and making that decision.
Okay, perfect. Thank you.
Any other questions?
Lillian, if we volunteer at the health booth, do we get a buffalo burger or an elephant ear or anything of that sort?
No, but you can get a sticker. That's the swag that we have. Is that an offer for volunteer? I can write you down. We can get you on the schedule, Dr. Atterbury.
I'm happy to do it. Yes, I'm happy to go out and talk about the benefits of vaccination.
Thank you.
Anything else?
Real quick, I was kindly reminded by Andre that at the last meeting we received public comment regarding PFAS in Yakima County, and I had a quick 2-minute update on that. So if the board doesn't mind, I can speak to that real quick.
Okay.
Okay. So the PFAS or perfluoroalkyl and polyfluoroalkyl substances, I pronounce that right. I practiced that, by the way. They're a manufactured chemical that don't break down. They're considered a quote unquote forever chemical. This is a really a problem that's seen nationwide. Roughly 43 states have PFAS contaminations in drinking water. In Washington State, it's believed and still under further study that firefighters' foam is the sole source of contamination in drinking water in Washington State. So, but still being studied to see if there are other potential sources of contamination. So what we, these are water soluble substances that are hard to filter out. They don't go away. Contamination builds up over time. So there's the concern around that aspect of these chemicals being in our drinking water. So it's not we're not the lead agency in this arena. The Washington State Department of Ecology is. I know Department of Health works on this, but we partner with those state agencies to be a source of information and support where we can participate in that. For example, there's the concern of PFAS contamination on the Yakima Training Center. So I helped the Department of the Army with finding contact information for all the residents that own the parcels surrounding that western border of the training center. So we are involved, but we're not the lead. And just for the board awareness, it is a concern, and we offer support where it's needed to our state agencies. So I hope that clarifies some stuff for you guys.
So Sean, I know that we had in the city, the Yakima Training Center, and some of the people from Lewis McCord came and talked to us about the situation when it was starting. They were starting to get, testing and reports. And the hope that was that it would be mostly contained within the area of the training center itself. And that has proven not to be the case, that they are finding more outside of the training center from drift. And I'm wondering if you know how they are in the process of testing that.
Yes, so of the contacts that I provided to the Department of the Army, I think there was well over 100. They got permission to test on 22 different wells. A couple of those were multiple connection water systems. They were only denied access to one individual well, so we got a pretty high rate of participation. They've conducted the first round of sampling. Results for that is expected to be back in about a month. Because they said 6 to 8 weeks about 2.5 weeks ago. So we'll see results from that. They'll be shared with us from Department of the Army. They'll be shared with Ecology, and I expect that we will all three of us agencies will sit down together and discuss next action steps for that.
Thank you. We have a couple more items to cover if everybody is done with the current reports. Is there any old unfinished business before us? Hearing none, let's move on to new business. And Commissioner McKinney.
I believe that.
Sorry, before you start that, I just wanted to say that I have to sign off at 11:30 a.m.
Yeah, we're trying to get that target date or time. Thank you.
I believe we've done a good job of touching on this. This is something that I was wanting to bring forward to the conversation quite some time ago. So I'm really pleased that federally we've acknowledged the benefits of treating COVID, especially using monoclonal antibodies. So I'm grateful for the great states of Florida and Texas to show us how it can be done. So I think that Mayor Byers, as indicated, what I would like to see in our agenda for next meeting would be the composition of a letter coming from the health board specific to our request and support and pursuit of receiving those continued monoclonal antibodies into our community and the state, and a request that the Biden administration consider doing what the Trump administration did, which is to purchase these treatments for the public and provide these treatments at no cost to communities. So I would entertain that as an item for our next agenda.
And who are you proposing that drafts that letter?
I think we can discuss that at our next meeting, but it would be something that the board can determine what the verbiage would be, and then we can approve it as a board.
Okay.
This is Dr. Clary. Just real quick, I did see that there was a U.S. News and World Report early in September about the Biden administration pledging $3+ billion for medical research. And it also mentioned that the administration was purchasing 1.4 million doses of the Regeneron plus 350,000 doses of the Eli Lilly monoclonal antibody therapy. So I believe that's probably already in process.
Would want to advocate for far larger numbers than those.
All right, thank you. Is that conclude then, Commissioner? Okay, good. We'll move on to the proposed motion under B, amend section 2.7 of the Yakima Health District's handbook. And who is going to speak to that? Oh, Ryan.
Yes. So the section 2.7 of the Yakima Health District handbook allows for overtime for exempt staff while an incident command or ICS is activated. And after conversations with Charles Ross, the county auditor, Judy Kendall, the Yakima County Human Resource Senior Manager, and Craig Warner, the Financial Service Director, it was recommended that instead of doing overtime that we do emergency response pay. This is a system a similar system that we already have in place here at the Yakima Health District. It also aligns with Workday, which is our payroll system at the county level, which is already in place too at the county level. And it just makes it for smoother accounting purposes. And so after discussions with the three individuals from the Yakima County, we agree that the emergency response pay would be more fitting than the overtime pay. And so there is a proposed motion to amend section 2.7 of the Yakima Health District handbook from overtime for exempt staff to emergency response pay for exempt staff.
Hey, would anybody like to make a motion?
I would make a motion to approve the amendments to the overtime and exempt staff pay for emergency response.
I'll second that motion.
It's been moved and seconded. Any discussion?
Hey, just a quick question about it. Is there any financial impact on this to the health district, or is it just a different way of categorizing?
It's a different way of categorizing it. Whenever we're in an incident command system, that we'd have to have the funding for it.
Very good.
Commissioner Lindy, actually, theoretically, it should be more cost effective. It should theoretically cost less.
Oh.
I would just like to say, I know that we talked about this several months ago, and we talked about overtime pay, and we were acknowledging as a board and as a community the amount of additional time that you and so many people involved on the front line of this pandemic have definitely spent far more time than was even conceivable. But we do have employment law that we wanted to make sure that we were following with regard to exempt employees. So I think that this is a wonderful solution that we're able to recognize the clear efforts that went above and beyond the normal call of duty, but still maintaining the precedent for exempt employees. So I'm just grateful for the staff, both at the county and the health district, who were able to navigate this solution.
Thank you, Commissioner McKinney. I would say that the process of figuring this out was far more labor intensive than we would have ever imagined. but we did hear you, and that's why we didn't move forward with any changes until we really ensured that everyone was in agreement. So thank you.
All right, well, it's been moved and seconded. Any further discussion? Hearing none. Ryan, would you take a roll call, please?
Yes, and if you're in favor of the motion, please state aye or yes. Dr. Cleary.
Aye.
Commissioner McKinney.
Aye.
Commissioner Lindy.
Aye.
Mayor Byers.
Yes.
Councilmember Duval.
Yes.
Dr. Atterbury.
Aye.
And Commissioner Anderson.
Aye. Thank you. Well, that concludes our regular meeting schedule. I will entertain a motion at the request of Council Lady Duval to adjourn before 11:30.
Mr. Anderson, before we move forward, I'd like to do this. I mentioned earlier in the meeting, I'm going to try to be very quick about this, that I have received a number of requests for information, and I brought a list of questions. So I want to simply read the questions into the minutes so that we can then address them during our next meeting. So they don't need to be addressed today. And a lot of them, I think, are probably going to be answered when people know what the access to the dashboard is, but I think also some people want raw data, so if we can have both raw data and graphs would be helpful. But here are the questions that have come in to me. One of the questions is they want numbers of both vaccinated and unvaccinated in the hospital stay and also in the new daily cases, and particularly for testing. The next question is, how are the deaths related to COVID actually audited? Their concern is that the numbers reported by the health district and the numbers of the coroner's office often don't coincide, and the health district numbers are often much higher. So what is audited there, or how is that done? The next question
For that
is—
one really quick, Mayor Byers.
Yes.
So the difference, we're always going to have conflicting numbers between us and the coroner's office because they have to record every death in Yakima County, whether the patient was a resident of our county, where the health district accounts for Yakima County residents.
Thank you. So I'm not looking for answers today. I just want it on the record because they asked me to do this, and then we can discuss it the next time. I'm trying to be conscious of the time. I know that Mr. Ball needs to go off. So I have a couple more questions here. The next question is that the health district has stated that hospitals don't give them information, for example, actual numbers of vaccinated versus unvaccinated, yet they generally state that over 90% of COVID patients in the hospital are not vaccinated. Is that determined from an actual count, or is that from the CDC website, which makes the same statement? The next question is, if it is in 2 weeks after the second vaccine shot to be fully vaccinated, how are those who without a second shot or less than 2 weeks after the second shot recorded when in the hospital as vaccinated or unvaccinated, and how many are actually breakthrough cases coming into the hospital? Okay, that's all the questions. I wanted them out there because I promised to ask. And
Mayor Byers, I have one more additionally that I'd like to add to that. I received several of the same questions, but one additional one that what constitutes hospitalization? So that was a question that I had received numerous times of, is it, if we could just get details on what exactly does it mean, what constitutes a hospitalization for what we're referencing, at least for COVID. And that's the only other question I had that was different. And then I do have one more request just to add an agenda item to the next meeting. I would like Mr. Elliott, if he would research the RCWs for vaccinations in Washington State. I think it would be interesting for this health board to understand how vaccine requirements are created through our legislative body in this state. So I would enjoy understanding that and who actually creates vaccine requirements as a legal requirement in our state, and what legal vaccination requirements are currently a part of our current RCWs. I note that there's a couple related to nursing homes, extended care, and schools, but I'm just curious if we can go through that process, Mr. Elliott, at our next meeting. Thank you.
And just one thing, the hospitalization probably is defined by inpatient, which would not count the ER.
Sure, I would love to know if it's hospitalized, if it's, if you stay there for 30 minutes and you're just, what actually is a hospitalization?
It's an order from an attending physician admitting you as an inpatient.
Mm-hmm.
so thank you for letting me get my questions on the record, because I know that people are looking for answers, and thank you for all the work of the staff and preparing responses for all of us. So,
and Mayor, if you would submit that to the board in writing, that I think that would be very helpful to them.
I would be happy to do that. Thank you. So if I get it to you, Andre, or to Ryan, you can get the questions out to the board.
Sure, as well as Commissioner McKinney's question.
Wonderful.
Yes,
Thank
yes.
you.
Yeah.
Thank you.
And we're almost
Okay.
at 11:30.
Okay, where are we? I think it's been moved and seconded, but I'm not sure.
Not had a motion to adjourn, though I will make a motion right now to adjourn.
And I'll
Okay.
second.
It's been moved and seconded to adjourn. Any discussion?
Thank you, right on time.
If not, we're adjourned. Thank you.
Thank you. Have a wonderful day.
Bye.
Thank you.